This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by.
Welcome to today's meeting of the Health Committee. Members of the public may like to follow at London Assembly on social media and use the hashtag AssemblyHealth for this meeting. And please may I remind participants to silence your devices. And the main item on the agenda today is our discussion on HIV in London. However, we have a few short items of business. And can I ask now our clerk, Diane Richards, to confirm any apologies for today's meeting?
Thank you, Chair. No apologies for absence have been received today.
Thank you. Can we note the list of offices held by Assembly members, and can I also ask members if they have any disclosable pecuniary interests in any specific items listed on today's agenda?
No, no.
Thank you. Can we confirm the minutes of the meeting held on 18th September 2024? Thank you. And I should also note the site visit that the committee had on the 16th of October to Brentfield Primary School. And can we note the completed and outstanding actions arising from the previous meetings of the committee? Thank you. And that brings us to today's main item. I'd like to extend a warm welcome to our guests joining us to discuss HIV in London. We have Jane Anderson, Professor Jane Anderson, who's a consultant physician in HIV medicine at the Homerton University Hospital and co-chair of the Fast Track Cities Leadership Group. Welcome. We have Tamara Juritic, who is the head consultant for HIV and sexual health at UK Health Security Agency, UKHSA. Welcome as well. Alison Brown, who's a consultant scientist for UKHSA as well. Welcome as well. And we will have joining us later Jonathan O'Sullivan, who is the Director of Public Health at the London Borough of Islington and the HIV lead for the Association of Directors for Public Health England, no, Public Health London, sorry. So we'll welcome Jonathan when he comes formally as well. But can I invite Tamara and Alison, first of all, to present their slides, and we'll ask follow-up questions afterwards. Thank you.
Thank you very much for your warm welcome. So my name's Alison Brown, and together tomorrow we head up the HIV section in UK Health Security Agency, where we focus on national HIV surveillance. But today we're going to pull out London data where it's available. Could I have the first slide, please? Okay. Yeah, thank you. Thank you very much. Back in 2021, the English government set an ambition to reduce HIV transmission by 80% between 2019 and 2025, and AIDS and HIV-related deaths by 50% between 2019 and 2025. This is part of a wider global ambition to end HIV transmission, that is, people acquiring new infections, by 2030. The ambition was set because we have been seeing a big fall in the number of people newly diagnosed with HIV, particularly in gay and bisexual men. So an HIV commission was set up to look at what the barriers and challenges were, and an action plan published setting that ambition and setting key objectives in order to meet that. I'm presenting today data that's going to be published next week. I am allowed to share it with you, but it is not formally published until the 28th of November. And on the 28th of November, we're also publishing our public health evaluation of the opt-out bloodborne virus testing in emergency departments, which you may have heard about as well. So this graph here on the right-hand side shows the number of new HIV diagnoses first made in England. You can see there has been a large fall between 2015 and 2020. This is the period from the baseline that we aim to see a reduction in transmission. And you can see, unfortunately, new diagnoses appear to have gone up with this slide, but it's not as bad as it looks. Next slide, please. So this slide here shows a number of new HIV diagnoses first made in the UK by London and outside of London. And what you can see here is that it's very difficult to interpret numbers of new HIV diagnoses. They don't necessarily show trends in incidence, and that's because they are affected by the number of people having an HIV test. They're also affected by people arriving in the country with a diagnosed HIV infection, and it's also impacted by certain activities. So since 2022, we've had a rollout of ED opt-out testing across areas of high prevalence, mainly in London. And you can see here, if you look on the London slide on the left-hand side, once we take out the additional diagnosis from the ED testing, we are actually seeing a continued fall in new HIV diagnoses in London. We have seen, however, a steep rise in new diagnoses outside of London, particularly in heterosexual and bisexual men. And that occurs even after we do the adjustment, trying to remove people who would not have been diagnosed had it not been for the ED testing. So we're doing that to look at trends to indicate incidence. So why do we think that incidence is still occurring? So next slide, please. The good news is that in gay and bisexual men, we do think there is a real fall in HIV incidence. This graph here shows the number of HIV tests taking place in a sexual health clinic. In dark blue is in London, and in orange is outside of London. And you can see for gay and bisexual men that even though there was a small dip in the COVID years 2020, 2021, numbers have since recovered and are higher than pre-COVID levels. On the right-hand side graph, you can see the proportion of people having a test who test positive. And you can see that has fallen over the same time period. So the fact that we're seeing a big rise in people testing together with a fall in new HIV diagnosis, shows that transmission is reducing in this population. However, this reduction is not seen across all gay men, and we're seeing most of the fall in white gay men. So, sorry, in 2019, 1 in 4 gay men who were diagnosed in London were from ethnic minority backgrounds, and that's now risen to 1 in 3 in 2023. And that's because we're seeing most of the reduction in white gay men, but continuing trends in ethnic minority men. And in London, we have seen small increases in diagnosis of Black African and Asian gay men. So to sum up, for gay men, there is a fall, but it is primarily related to white gay men. Next slide, please. For heterosexual men and women, we believe HIV transmission is continuing. On the left-hand side, again, it shows the number of people having an HIV test. Again, blue is London, orange is outside of London. And you can see here, unlike with the gay men, the number of people having a test has not recovered since COVID. We're seeing much lower numbers of people still having an HIV test. And that combined with a steady rate in positivity, that means the proportion of people testing positive, shows that we think HIV transmission is continuing in this group. We can see that in London there was a slight increase in heterosexual men and women being diagnosed, but a much larger increase outside of London. But if you look amongst Black African heterosexuals in London, you can see there was a small increase from 128 in 2022 to 158 in 2023. So we believe transmission is continuing in this population. Next slide, please. So why is it that we are seeing continued transmission? I mean, the good news is we have the tools to end the epidemic. We know what works, which is high levels of HIV testing, access to PrEP, which stops people from acquiring HIV, prompt treatment, which saves lives and means people can't pass on the treatment if people are virally suppressed. And the good news is we have excellent care and excellent prevention activities across the UK. This graph here shows what is commonly referred to as the UNAIDS targets, and they're called the 95, 95, 95 targets. And the aim is that 95 people living with HIV are diagnosed, 95% of people who are diagnosed are treated, and 95% of people who are treated are virally suppressed. And the good news is that we're one of the few countries that have met that ambition. And you can see that's very much the case in London on the left-hand side, as well as outside of London. However, if we dig a little bit deeper, we can see that there are some inequalities there. We think that we estimate that a quarter of people living with undiagnosed HIV infection live in London. We know that treatment coverages are good across all groups, but we do know there are also some inequalities in viral suppression in younger people and in people who inject drugs. It's still very high, it's about 90%, but there are some definite inequalities there. So, next slide, please. So what can we be doing better? What do we need to do better in order to reach the 2030 targets? This slide here shows the proportion of people attending a sexual health clinic who are offered a test and accept a test. And you can see on the left-hand side of all people having offered an HIV test, 76% of people accept a test. Amongst gay and bisexual men, it's very, very high, with 96% of people accepting a test when offered. But what is particularly of concern is women. Women are on the last two columns, and you can see the penultimate column is Black African heterosexual women. And here you can see only 78% of women are accepting a test, compared to 64% amongst women of other ethnicities and Black African. And that's a particular concern, because these people are attending a sexual health clinic, so presumably are sexually active and should be offered a test. And whilst it's concerning, whilst there's not particularly much difference between Black African and people of other ethnicities, what is of concern is we know the positivity in Black Africans is much higher than in other populations. So by failing to offer a test, excuse me, so by failing to accept a test, failing to adequately ensure people are having a test, we are missing opportunities for diagnosis. Next slide, please. Okay. An HV diagnosis gives the opportunity for pre-exposure prophylaxis, which is a drug people could take to prevent people from acquiring HIV. And the number of people accessing PrEP is increasing year on year, but there are some stark inequalities. In this graph here, the dark blue line shows the proportion of people who are starting or continuing PrEP. And you can see this is much higher for gay and bisexual men, GBMSM, than it is for heterosexual men and heterosexual women. There's also regional variation, with London doing quite better than some of the other regions, with 78% of people who have a PrEP need starting or continuing PrEP, but there are inequalities by ethnicity and region. Next slide, please. So this slide here, on the face of it, shows good news, but we can also invert it to show where we need to do more, and it also doesn't show the whole picture. So it looks fantastic that 95% of people are diagnosed. It looks fantastic that 98% of people are treated. And it looks fantastic that 98% of people are virally suppressed. But we can also have a look at the numbers who haven't met those targets. And those numbers don't include people who are linked to care and people who are not retained in care. And next slide, please. And this is what we attempt to do now. So this slide is quite confusing. We have different scenarios, and we're trying to estimate how many people are living with HIV with transmissible levels of virus. And that means people who have HIV that is detectable and could theoretically pass HIV on if having sex without condoms or PrEP. And you can see here that we estimate that about 15,000 people, in the middle bar here, have transmissible levels of virus. Of these, we estimate that 29% are undiagnosed. 2% of people aren't linked to care, so that means they've been diagnosed but haven't made the transition into HV care to start treatment. We have 31% of people who are diagnosed but not in care. They've dropped out of care or not been supported to continue their care. 10% haven't started treatment, and 28% are not virally suppressed, or they have no indication of viral suppression. If we break that down, about 5,000 people are gay and bisexual men, and 4,000 are Black African. Okay, next slide, please. We're now looking at some of those components in more detail. On the left-hand side shows proportion of people who are linked to care within 2 weeks of diagnosis. Most people are diagnosed in sexual health clinics and are diagnosed, 84% of people start treatment within 2 weeks of diagnosis. But you can see it's really good that we are promoting HIV testing in other settings outside of sexual health clinics, such as A&E settings and GPs and other outpatient settings. But there's less efficient linkage to care in those settings. So we must make sure that any innovation we have to expand testing is matched by very good pathways into care. We also know that there's more we could be doing in terms of retaining people in care so people are supported, and that can be attained through peer support and then making sure that services are accessible and continue to be welcoming. So overall, we estimate about 5% of people are not retained in care year on year. And that's about 4% in gay men and about 5% in heterosexuals. And we do know there are some inequalities there, with Black African men and women outside London in particular being less likely to be retained in care. And then finally, we could be doing more in terms of peer support in making sure that people who are receiving treatment... Sorry, next slide, please. there's a lot more we could be doing in terms of supporting people who are on treatment to adhere to treatment so that people become virally suppressed. And if you're virally suppressed, you have undetectable virus and can't pass HIV on. And what you can see here is that we have London in blue and outside London in orange. And you can see that in London in particular, we can see that we are seeing a proportion of people who are not virally suppressed is worse in black African heterosexuals compared to non-African black heterosexuals, and better in men. So there is some inequalities there in terms of region, and then also in terms of making sure that everybody is supported to take treatment. So we know from some research that people who are supported with peer support are more likely to successfully adhere to treatment and no longer pass HIV on. Next slide, please. And the good news is that HIV is, of course, changing. Treatment is now so effective that people can expect to live long, healthy lives with HIV. And for most people, it's 1 pill a day. And obviously, if you have HIV and you're treated and virally suppressed, you cannot pass HIV on. As a consequence of this, the population with HIV are ageing. So if you look at this slide here, you can see now that more than half of people living with HIV are now at age 50 years and over, and that's a good news story. But it does mean that we need to make sure that we are serving the needs of the population as they age, as people with HIV age, to make sure that services are joined up and care services are competent in how people are dealing with HIV and treating people with HIV. Next slide, please. So there have been successes. We have reduced HIV transmission, particularly in gay and bisexual men. But despite world-class care, we are unlikely to meet the 2025 targets. The rise in London in diagnosis is likely to be impacted by the EDOPT bloodborne virus testing programme, and that will be published on the 28th of November in more detail. And the fall in transmission we've seen has largely been focused on white gay men, and we've seen no evidence for decline in ethnic minority gay men, and we think transmission is continuing in heterosexual men and women. This is both in London and outside of London. The good news is that we have the tools to end HIV transmission. We know that testing is key, PrEP is key, getting people quickly on treatment is key, and making sure people are supported to have an undetectable viral load so that it's not possible to pass HIV on. But we do see there are stark inequalities in terms of heterosexual women in particular not having an HIV test, in terms of access to, in terms of people accessing PrEP, also in terms of once people are diagnosed in relation to being retained in care year on year. The good news is that next year we're going to be publishing together the Department of Health and key stakeholders a new action plan where we're going to confront some of the challenges and the gaps that we have at the moment. And we're considering what we could do to make it a success for 2030. So we can make sure a number of things are implemented, such as we have a good range of HIV testing guidelines. We need to make sure that we implement these effectively. We need to deliver culturally competent testing initiatives in lower prevalence areas. We are seeing increases outside of London, and we need to make sure that those areas are equipped to deal with it. We need to implement the PrEP roadmap that we have now, thanks to this action plan. Invest upon notification of peer support so people with HIV have the support they need to be in care and access treatment. And also address the very real stigma people living with HIV are still experiencing, which is a barrier for testing and also a barrier for accessing other parts of healthcare as well. Thank you very much.
Thank you, Alison. Thank you for battling through that as well. I'm going to just take this opportunity before I ask questions to welcome our students and professors from the Caxias University in Brazil. So welcome. Hola. And just an opening question from me, because the data that we had been looking at as a committee prior to this meeting just seemed to suggest an increase in new cases across London. You've suggested, I think, in your presentation, Alison, that actually new cases are set to go down in the data that you publish, that you're set to publish next week. Can you just give a bit of an explanation on that?
So overall, there are two different. So first of all, we divide HIV diagnosis into two categories: diagnosis first made in England, and then diagnosis amongst people who are continuing their HIV in the UK. That means people who were diagnosed abroad and then have arrived in the UK. So it's a new diagnosis in England, but not a new diagnosis in terms of transmission. Because we're interested in transmission, we only look at people newly diagnosed in the UK, and there's still an uptick. But because we're interested in transmission, we also we took out people who were diagnosed through the expanded emergency department setting, where there are about 400 diagnoses, to see what the trends in transmission were. So once we remove those, there is a fall in HV diagnoses. The reason why we want to remove those is a good public health story, but if you're tracking diagnoses over time, it's not a fair like-for-like comparison to suddenly have a huge program of over 1 million people tested to make a fair comparison. So we're noting those, but we're saying, in terms of transmission, we think there's a slight decline now.
Tamara?
Thank you, Chair. I just wanted to add, so what it is it's increased testing, obviously, that it's picking up these people, and we, out of all ED testing new diagnoses, approximately about 70% of those in London. So I think the good news is that we are picking up those people we wouldn't have picked up in sexual health services and other services we have. But when we look at the incidence, which is a new transmission, it does look like that these people are a result of a presentation to services rather than new transmissions, if that makes sense.
Yeah, so you're looking at new transmissions rather than new, let's say, individuals in the UK living with HIV that you know about now.
Yes, I think what's a little bit confusing is so the target for HIV Action Plan and 2025 and for the WHO is to get to zero transmission by 2030. And the way how it's measured is not necessarily only new diagnosis, because new diagnosis could be new transmissions, but it could be also that people had the infection for some time, but they are just presenting because we have more testing opportunities for them to be tested. So what we're trying to say is, yes, we are seeing increase in new diagnoses overall, but in terms of that particular new transmission, it might have not been equal. New diagnosis might not be equal to new transmissions.
Okay.
Hope that makes sense.
Yeah,
Sorry, it's a little bit complex concept to get across.
It does, but I think from other assembly members may want to come in, but from my perspective, it's just to make sure that we are not changing the goalposts as such and are comparing like for like in what we have done in the past. Yeah. Alison?
Yeah, we use new HIV diagnoses first made in the UK as a proxy for incidence, but we do have models underlying, which I didn't present today, where we effectively model incidence, and that has shown for gay men we have seen a reduction in incidence, but unfortunately we don't have models for heterosexual men and women, but we're working on it.
Okay. And
sorry, incidence is the rate at which people acquire new HIV infections, so that is how much HIV transmission the rate at which people are acquiring new infections.
Okay. And just looking at the information and data you presented, Alison, on London versus outside of London, and I mean, it from our perspective, it looks positive in terms of what you presented in outcomes in London compared to elsewhere. But what are the reasons for this, particularly looking at the new diagnosis figures?
In London, in particular for gay men, we were doing a lot better at the number of tests in gay men. There are lots of, you may have heard of places like Dean Street, for instance, where it's encouraging men to have tests very, very frequently, combined with very ready access to PrEP, and then if people do become positive, quick access to treatment. So I think that probably initiated the start of the fall in gay and bisexual men. Jane may be a better person to answer that question from Fast Track Cities in London.
Jane.
Sorry, Jane, is that okay?
Yeah, go ahead.
Well, thank you very much, Alison, for passing it over. But before I start, first of all, I'd just like to say good afternoon on behalf of everybody in London who's involved with the Fast Track Cities Initiative, which is many, many people, including my co-chair, Professor Kevin Fenton. And I'd really like to thank the committee for putting HIV on your agenda, because we do, as I think you've heard from Alison and Tamara, have quite a lot to celebrate. But even with all the resources we've got, we have to really continue with a concentrated and collaborative effort if we're going to go the distance. And I do want to congratulate the Mayor and his team for the support that they have given to this initiative so far. Just to summarise for you what the Fast Track Cities Initiative is. Fast Track, it's a very simple phrase that actually encompasses the complexity that is the HIV response in this city. It is a collaboration between UN-AIDS, UN Habitat, the City of Paris, and the International Association of Providers of AIDS Care, set up in 2014 when, as you heard from Alison, it became clear that if we could achieve 90-90-90, we could see the end of AIDS as a public health threat globally. And so this was an initiative to support cities to fast-track their response to meet those 90-90-90 targets. And in fact, London joined the initiative, the global initiative, in 2018, by which time we had already met the 90-90-90 targets. And so London set itself the ambition of getting to zero. Zero new infections, zero preventable deaths, zero HIV-associated stigma, and best quality of life for Londoners living with HIV. So that's the context that this piece of joined-up work is sitting in. Why is it important? Well, it's really important because all the various bits of the HIV treatment and care pathway are quite scattered and dispersed, and it's really important to join everything up so that there is a seamless transition between many of the things that Alison and Tamara have talked about, between testing, prevention, treatment and care, long-term care, stigma. All these things all need to be joined up together, and the Fast Track Cities Initiative in London brings together everybody in our city, every organisation in our city that has a role in doing that. And it is the only place in our city, our great global city, where everybody who is interested in getting to zero HIV transmissions, the ambitions of the programme, sit down round one table to work together in partnership and in collaboration. I should also let you know that there are many other fast-track cities across the world now. There are about 300 to 400 cities that have joined up. And in the UK, we have Manchester, Liverpool, Brighton, Birmingham, Bristol, Leeds. Wales has joined up as a country, and so has Scotland. So actually, all the cities inevitably are different, and that is one of the great joys of this programme, because each city is tailoring its programme to meet the needs of its particular communities and populations. And yet, if you put all those cities together across the UK, we've actually got enormous coverage and a network across our cities. And that, of course, is important if we consider the mayor and the metro mayors, because there's a really great opportunity for people to be doing some fabulous joined-up working. So that's where we've got to, and that's where the initiative sits. But to go back, I guess, to Alison's point and question, our initiative in London has been undertaking a number of particular partnership projects, and over the years since the initiative has been in place, in particular between it was just before the pandemic, early 2020 and 2023, we undertook a large collaborative project which initiated a huge array of support and tests across the city. They were demonstration projects. because one thing I want to really ensure that the committee understands is that the Fast Track Cities initiative is a mechanism for partnership. It's a mechanism for collaboration. And many, many organisations in our city are doing fabulous work and have been doing fabulous work. This is a way of bringing things together to be greater than the sum of its parts, and also to try out things in a way that enables people to have the evidence base and the data to go forward, perhaps into the future. We're very keen that the things that we try out are either pilots that people can pick up, or they are things that at the moment ought to happen but are nobody's particular responsibility. And that was what happened with many of those testing initiatives, and some of those have gone on. But they were things like, for example, we had a particular initiative looking at health and social, at financial support, because we know that one of the big issues for people who are all in an age of austerity, who are already marginalised, is financial hardship. And we looked at a mechanism for ensuring we had financial support services in clinical settings, and actually managed to secure over £1 million of benefits for people living with HIV to enable them. They were benefits they were due to get but hadn't been able to claim for various reasons, which enabled them then to become better engaged with treatment, to stick with their tablets, to remain undetectable, to ensure that they were not infectious to other people, to live long and good lives. So those are the sort of particular things that we've been doing in Fast Track Cities. And you can go to our, I can't cover them all because we haven't got time, but you can go to our website and you'll be able to see all the projects that have happened, that are ongoing, and things that have gone forward.
Thank you. And if you can send us information after the committee meeting on the different programmes that you have that are London specific, that would be, I think, welcome to see what's been happening in the capital. I'm going to turn to Assembly Member Boff.
You've given a very, Ms Brown, you've given us a very full reply about the health inequalities that there are with regard to testing. Are there international comparisons to see whether or not that is, who is the minority group that we should be addressing, or does it shift from city to city depending upon their own demographics?
So do you mean international as comparing country to country, or do you mean
or even city to city,
okay,
to see if there is you've cited particularly Africans who have who aren't testing as much. Is that reproduced in other cities? Is that the case in other cities outside the UK, or is it a particularly UK phenomenon?
Yeah, so we attended the International AIDS Conference a couple of months ago, and it was overwhelmingly, if you like, apparent that as we are approaching the last mile, if you like, of reducing transmissions, what we're seeing is slightly a change in epidemiology across the world. So as when the pandemic started, it was always about gay, bisexual, and men having sex with men. And there's been a lot of work, but also stigma in that population group has significantly reduced. Whereas when we, for example, did a piece of work like a survey on Positive Voices, which was over 4,000 people who live with HIV in this country, you see the stigma is still apparent in heterosexual population and those from ethnic minorities. So that contributes also to not being tested and not going forward. So that's actually the same across the world, but there are different reasons why that is obviously the case. But in this country, it does look like, when we look at the data, that potentially, because of stigma, that especially in frontline care workers, that testing has not always been offered when it should have been.
And the figures you produced about heterosexual women being less willing to come forward, is that reproduced internationally as well, or is that just that?
I think that's the setup we have in the UK, how people test varies from country to country. In the UK, most people at the moment are still testing in sexual health clinics. and there are some issues with the data in terms of some people might say that women are coming for reproductive choices only, and therefore it isn't right to make sure that everybody's having a test. But I think that it would be a very quick win to try and make sure that it almost becomes an opt-out, if it's properly funded, for people to go to a sexual health clinic to have an HIV test, because we know these people are sexually active. But I think it's also a matter of access as well. We're very much depending on people coming forward to sexual health clinics. I think we need to be more imaginative. We have testing guidelines. There's more we could be doing in terms of, we have a set of what are called indicator conditions. So if you turn up with TB or various types of pneumonia, you should be offered an HIV test. And we could be doing more to make sure those testing guidelines are implemented as well, because not all people will attend sexual health services. We need to make sure we improve access to an HIV test.
Can I chip in?
I was just going to clarify, because I saw you frowning on opt-out. What it means is anyone who comes into the clinic should be offered a test regardless, unless they opt out from that. At the moment, that doesn't happen. It depends on the clinician what they think the risk factors are.
So I was just going to pick up on the issue of people who are not attending sexual health clinics, and that's really, really important. And we are now, I think, we've seen the results of the opt-out emergency department testing, and more women, I think, are coming through those doorways, and people who actually might otherwise not have accessed tests. And now we know this, London was an early adopter of the opt-out testing in EDs, and in the couple of years since it's been going, the latest data suggests that about 1,300 people have been diagnosed through emergency departments, and importantly, of those, about 900 are people who are newly diagnosed, going back to Alison's earlier point, but something like 600 are linked in to people who have been diagnosed before but have not been in care. So another test enables them to get back in. So this whole concept of one test may not always be enough, because if somebody's fallen out of care, then a second test in opt-out settings, perhaps in a GP surgery as well, will pick up more people. And we have got within the Fast Track Cities initiative at the moment a project looking at GP champions, and across London we have 16 general practitioners who have, they're now covering all the 5 ICBs, which means that they are there to really work with their colleagues in primary care to get the message about HIV, who should be tested, what they can do in general practice, linking in with the anxieties that people living with HIV, which we've heard from the Positive Lives survey, people are reluctant to go to their GP because they fear stigma, or sometimes they fear their GP might not know enough. But in any event, we know that people are not particularly comfortable going to GPs. And so we now have in our city 16 GP champions who are actually doing a fabulous job trying to reverse that. And I think that will change some of the testing initiatives in our city.
The fight against HIV must surely sit within a wider sexual and reproductive health strategy. But as far as I know, that doesn't exist. Is that something that would assist us?
So that's an important point, because as Alison's alluded to, we have an HIV action plan.
Yes.
We have a new administration that has pledged itself to refresh the action plan, and that we hope is going to be, there's work on that happening at the moment. But we do not have a sexual health strategy in the same way. There are frameworks. UKHSA has very helpfully come up with some guidance relatively recently, but the strategic approach that HIV has adopted has not been replicated in wider sexual health. And I think when Jonathan comes, it'd be important to check in, because actually an awful lot of the sexual health work is happening in local authorities, in their public health agenda, and actually unless that is right, we are not going to hit these targets. It has to be a joined up piece, and I think it's really important that the sexual health agenda and the HIV agenda are better coordinated.
Even though the Mayor doesn't have a direct role in those services, do you think it would be a good idea that he should be using his convening power to encourage those local authorities to cooperate more in producing, well, a needs assessment of what is required of a sexual health and sexual and reproductive health strategy?
From my perspective, speaking from the Fast Track Cities initiative, the Mayor has signed up to London getting to zero. He has given us his full support. Without the sexual health agenda being adequately resourced and followed, he's not necessarily going to be able to deliver on that ambition. And so I think it would be great if he could continue to advocate wherever he can for the getting to zero HIV, which he's absolutely committed to, through all these other routes. And actually, although the sexual health agenda is one of them, there are many other places where the Mayor has got fabulous influence, with the police, with transport, with faith leaders. All those are places where actually using his convening power, using his support in this particular agenda, he could really help us make a difference.
Thank you. Thank you, Chair.
Thank you. Assemblymember Best.
Thanks. Alison, I wanted to ask you about the data and perhaps your confidence in the data. How confident are you the data, say, that you're presenting today is capturing everyone diagnosed with HIV in London? And I mean, or is there any further information sharing that would help you be more clear in those stats?
Thank you. HIV is rare in infectious diseases in that it's not a notifiable disease. So there are a range of infections across the UK where clinicians are mandated to notify us of that condition. That's not the case for HIV. So we are reliant on what we call voluntary reporting. But we do think the data are complete, and that's for a number of reasons. We can accept an HIV diagnosis report from any setting in the UK, and also we use that information working with NHS England to fund the services. So if the data don't reflect, if the data are incomplete, it affects how much each service gets paid effectively. So that makes sure that it's complete. We also are able to link patients year on year, so we can look at patient outcomes and who drops out of care. I think in terms of how complete the data are, I don't think we need assistance, but where we do need assistance is probably the promptness of the reporting of the data. There is a lot of frustration that it takes us a long time to report data related to the previous year. In reality, we should get full reports to us in January for the previous year. In reality, we don't get them until July, which leaves us about 2 or 3 months to clean and validate the data and do the report writing. So in terms of the comprehensiveness, great. It's the promptness of reporting that we need to work better with services.
Thank you. And in terms of numbers, what's the number that you would estimate now of undiagnosed people in London with HIV? The estimate for 2023 is 1,300. I can't remember the credible intervals. For undiagnosed, it's a modelled estimate, which means it's not an exact number, and it comes within a credible interval range, which is the range within which there is 95% certainty the true number lies. Yeah. Okay, yeah. So about 1,200 in London. Thank you. And across the country, there's 14,000 people lost to care. What do you estimate that number is in London, or do you have an estimate of that number?
It is on the slide. I can't remember it off the top of my head. It's retention in care. Okay, here we go. So overall in London, we estimate about 850 people are not retained in care. Oh, sorry, that's violence suppression. I'm so sorry. Okay, we estimate that about 1,400 people are not retained in care year on year, but I would need to check those data.
Thanks.
It's about 5% of people each year. And then we do know that about half of those people do actually get re-engaged in care a year later. So there are, there's a difference in patterns. So some people are lost to care for good, and some people just have what we might call intermittent attendances, which is not ideal in terms of making sure that their needs are cared for and being adherent to treatment.
Thanks. Because I see that in the graph here, we've got 98% of people, diagnosed people, linked to care. Does that need to better reflect lost to care, perhaps like how the stats do in Scotland?
It does. So we are publishing that next week on the 28th of November. We're publishing the 95, 95, 95 data that also takes into account people not retained in care. So for that metric, it still is extremely high. I believe it's something like 94% of people who are living with a diagnosed HIV infection, and then something like in between about 95% of people on treatment, and then something like 92% virally suppressed, so still above the 90. But what's important to say is we are world leaders in national HIV surveillance, and most other countries struggle to calculate the 90 metric. So it's only because we have this comprehensive data set that we're able to track each individual person living with HIV over time, that we're able to account for people not retained in care. So this is not just an issue for the UK, it's a worldwide issue that the 95 doesn't account for those retained in care. So next week we will be publishing the 95 that also takes into account those not linked to care, those not retained in care, and also people for whom we have missing information.
Thank you. That sounds like
Could I just chip in there, because I think it's very apparent as we meet other cities and talk to other cities that the data that we do have in our country and our city is enviable. And we should be extremely proud of the data sets that we have. And it's only because we've got such good data that we can see now where some of the gaps and some of the extra bits that we need to fill in are. So I think I would absolutely commend the UKHSA for the work they've done, and we are, I think, in the lead for many, not necessarily that it's all perfect, but certainly we've recently been on a visit to Amsterdam, because the Amsterdam team are working in a way that's quite similar to London, and we went there, and actually one of the things that they quizzed us on was how the data works, and we had some extremely useful conversations sharing information. So our city is well equipped. We now need to tweak it, and we also, I think, need to think what else we need to collect, given that we're getting to these very small numbers, because actually in a city of 6.5 million people, a few thousand is small and really, really critically important to absolutely understand. So it may be that the data sets that we have, we may ask for some extra bits to give us a little bit more depth in some areas.
Thanks. And Alison, if I could turn back to the graph on the new HIV diagnosis, and I just want to be really clear, the diagnosis is first made in England. That refers to people that have been previously diagnosed, not just somebody that is arrived to the country and is being diagnosed.
These are people who are diagnosed for the first time in their lives, and that diagnosis occurs in England. So diagnosis first made in England. Is that what you're asking? Yeah. So we collect information on people who have an HIV diagnosis, and we divide those into two categories. People who are first diagnosed in England, that means somebody who tests positive for the first time in their lives, and that happens to be in the UK. And then we have people who are diagnosed abroad, and they have since arrived in the UK and then approached the Sexual Health Service saying, I have HIV. The first thing a clinician would do would be to test for that HIV, and it comes through as a new diagnosis. So we separate out those two categories. So in here, are you looking at the slide showing, okay, so these are only people who are first diagnosed in England. So it takes out, they're not included in this graph anywhere, people who are diagnosed abroad. Half of diagnoses now, all diagnoses in the UK, amongst people who are diagnosed abroad and then have since arrived in the UK. For us, it's really important that those people are rapidly linked to care and on treatment. And we know that 70% of people who arrive in the UK having had a diagnosis abroad are virally suppressed on arrival, which means they've already had access to treatment and can't pass HIV on. But it depends on what thing you're looking at. If you're looking at what's happening to rates of transmission, we take them out because that individual acquired HIV outside of England, therefore that's not our responsibility in terms of how that person acquired HIV. Once you've arrived, it is our responsibility to make sure that person is on treatment, virally suppressed, and therefore can't pass HIV on. So it depends on what you're looking at. If you're measuring transmission, we remove them. If you're looking at making sure that everybody living in the UK with HIV has access to treatment and care, we include them. Does that make sense?
The explanation does make sense. That's sort of the second part of where I was going.
Yeah.
But I'm not sure on the data still. I'd kind of like to see whether that, not necessarily now, but the separation of the numbers of those coming with a
it's in our main slides, so I could send that to you. Thanks. Where we explain it more clearly.
But I think the root of my question you answered, which is those that are coming to England with a diagnosis and turning up and saying, hi, I know I have a diagnosis, can you test me? And linking those people in to make sure they continue care, which I think
and that's something we need to get better at, because we have seen a rise of people who are continuing HIV care in the UK. That number has increased enormously over the last 2 years, particularly outside of London. So it really is vital that people are signposted to care very, very quickly. That is something we need to be better at. We're doing a good job already. It's just that outside of London, people are arriving to quite rural areas where services may not be set up for a bigger increase in numbers. But in terms of tracking the epidemic, it's not relevant, but it is relevant in our public health response.
Yeah. And finally, from me, it said obviously in the slide we're unlikely now to meet the 2025 target. Where do you see London in terms of meeting the 2030 target?
Okay. I think it's very possible we could achieve this, particularly in gay and bisexual men. In order to do that, we need to make sure we implement the successful strategies and make sure they're culturally competent and accessible for all groups of gay and bisexual men. So we know from all the initiatives that Jane's been talking about in terms of expanding testing, encouraging frequent testing, PrEP for everybody who needs it, rapid diagnosis and linkage to care and treatment works. So that is the good news, but making sure it's accessible for all cultures, for all populations, is particularly challenging. For heterosexuals, a huge part of that needs to be improving access to testing. Testing is the key to everything, because an HIV diagnosis gives access to PrEP if you're HIV negative, and sexual health advice. If you're positive, it leads to treatment, which means you can no longer pass on HIV. So I think it is possible, but we need to implement those tools in new and innovative ways.
Can I add to that? Yes, because I completely agree with Alison. I think it is entirely within our grasp. We have the tools, we have the resources. However, we know that an awful lot of people are not accessing the treatment and care they need. They're not accessing the testing services they need for all sorts of reasons. And one of those big reasons is stigma and discrimination and fear. And so we have got an enormous piece of work that we need to do for people to actually feel safe and comfortable accessing the services, to know they're there. There has been a sense that some people are, inverted commas, hard to reach. I think it's absolutely clear that if services are put within the reach of people, they will always use them. And so the initiatives that we have within the Fast Track Cities programme at the moment, we have a anti-stigma work stream where we actually have now got, I think, quite a lot of very good work going on. We have the HIV Confident Charter, and you'll be hearing more, I think, from both Robbie Curry and from Richard Angel in the next panel about some of the work that they're doing against stigma. But it is absolutely critically important that we get that bit right, because the technology is there, but the actual human responses and the ability of people to feel safe in those environments may not be there. We know there is stigma within health healthcare settings, which puts people off using them, and all those things need really clear work to improve. One thing I think is important, and I know Alison is working on this, is what measures we've got of stigma and discrimination, and to know whether the programmes that we're putting in place through the Fast Track Cities initiative have actually had an impact. And that is work that I think is ongoing at the moment, to look at how we would be able to quantify some of those initiatives. The Positive Voices survey has got some of that data within it, but it's critically important that we are able to have some metrics to know whether some of those wider issues, which we know are roadblocks, are actually are improving.
Thank you. I'd sum up that's where the dial is, because Alison, I think you've said quite plainly, is for men who have sex with men, ending new cases by 2030 is entirely likely, but it's in those other groups that it is not, quite frankly.
I certainly think we can make huge progress. 6 years is a long time. If we were able to scale up and provide accessible services, no reason why we couldn't see a huge decline in other populations as we do in gay men. What I'm saying is, for gay and bisexual men, we have a proven track record that we made a huge impact in transmission, and we can accelerate that. But as Jane says, everything is to do with access. And at the moment, services just simply aren't accessible for the large part of the populations affected by HIV, and that's where we need to work on. And stigma is a huge issue on that. I don't know, Tamara, if you want to pick up on some of the stigma stuff.
Can I just add to that? Because I think we are, one thing we absolutely have to get better at is testing for women. Because we have got contraceptive, reproductive health services. And Alison has shown us the data that women are coming into these front doors and services. They are sexually active, and yet HIV testing isn't happening as much as it should. So I think there's a real place for increased testing in those settings. And again, this is something that is linked in with the local authority public health agenda. And again, I think it's something that I'd like to know how Jonathan could see the London Sexual Health Programme perhaps supporting greater testing in those sorts of environments.
Thank you. Just on the same theme, really, about the 2030 target. I mean, you've identified some of the main challenges. It'll be interesting to hear from you some examples of what steps can be taken to address diagnosis, particularly amongst ethnic minority groups. Alison, maybe I'll start with you first and move to Professor Anderson after.
I mean, the good news is we already have very good testing guidelines. And we could be doing more. So we have guidelines. So, for instance, if you're living in a high or extremely high prevalence area, which everyone is in London, then you should be offered an HIV test at your GP when you register, and I think at least annually as well. We need to try and work with GPs to try and encourage that happening. We have indicator conditions. If you present with a range of different conditions, such as TB or pneumonia, again, you should be offered an HIV test. So we need to make sure that we have the resources there to implement those guidelines, because those, as we said, we don't think necessarily ethnic minority populations are accessing sexual health services as the extent of white gay men, for instance. And then there's more that we want to do in terms of, we talked about perhaps doing opt-out testing of sexual health services. And then we also have community testing as well, which we know is more acceptable for some populations. And we know from the work Tamara's doing that people who are having testing community settings, 1 in 5 people are testing for the first time. So that's increasing access as well. We also have online testing now, where people can access tests online. And we know that there is a wide range of uptake of that. In fact, that's one of the main things that's happened since COVID. So half of HIV tests through sexual health services have been procured online by people. So that is also increasing access. But I don't think it's necessarily compensating for the difference we have by ethnic groups.
Tamara?
I just wanted to add to, just as an example, so for example, when you look at the emergency department opt-out testing, so that's the test offered for HIV, hepatitis B and hepatitis C for anyone who comes to A&E and has a reason for bloods to be taken for other reason. When you look at the data, almost in London and outside London, but it's unpublished, almost 80% are in people from heterosexual background, and then quite a lot. And people who come to ED are more likely to be women. They're more likely to be of Black African and Black Caribbean origin, and more likely to be of over 40 years of age. So, what is it in ED department that makes people just being tested? Because it's opt-out, I guess, but it's much less stigmatizing because it's offered for absolutely everyone. So we need to replicate that in other services. That comes with a cost. Our sexual health services tell us that they probably can't afford this. So it's working with the national government, I guess, to make sure that additional resources are available. And then in terms of primary care, we've got in Fast Track City in London, I think it's the only one who has GP champions. But because there was a funding, that funding does expire in January. And I guess it's thinking about how we could potentially incentivize primary care to do more.
Okay. And can I just add to that? I mean, within the communities, there are a number of voluntary sector organisations, and I know you're coming into this into panel 2, but at the moment, in the current climate of austerity, a number of voluntary sector organisations are struggling, and those are the organisations that are working directly with communities affected, and unless they are supported, we are going to not make the inroads into the communities that need the support. So there's something here about ensuring that the voluntary sector is adequately resourced and supported to do some of this work. The health service itself is doing quite a lot, but it also is lacking resource, and certainly the local authority public health grant is not adequate to do the sort of level of work that we need. But unless the voluntary sector is also supported, we're not going to get the testing and the engagement from all the communities that need the services that are available.
Thank you. Thank you. We had some specific questions. I think we don't have Jonathan yet, but if he's unable to make it, I think we'll send him the questions in writing to get that information from the borough perspective and Association of Directors of Public Health. But I'm going to move on to Assembly Member Ahmad.
Thank you, Chair. Good afternoon, panel. Could I go back to the issue of people lost to care, and just on the back of what Assembly Member Best was asking? So 2 questions. First of all, why are we losing people to care? And secondly, it's a question that I am going to be asking the panel, the second panel, but I'm going to ask you as well. So how effective have the programmes in London been to re-engage people living with HIV who aren't in care, and what action would you like to see taken to expand these programmes? And I think, Alison, you said that 50% of those people that we lose to care do come back, a year later. So very interesting to see why that is, and why it is that the other 50% aren't, and what can we do to encourage that?
This is something we're looking at right now in more detail. So the British HIV Association guidelines suggest that if you're living with HIV, you should be, if you're stable, you should be accessing HIV care at least once a year. So we define people not retained in care as people not seen for at least 15 months to give that a bit of uncertainty. There are varied reasons. So, as Jane was mentioning earlier, a lot of the outreach things are in terms of making sure that people have benefits, etc. Sorry, start again. So, a lot of people living with HIV, it might be difficulties in terms of transport, childcare, mental health problems, problems with alcohol or drug dependency, which means that people aren't able to prioritise HIV care. This will vary enormously. That will be the case for some people with HIV. For other people, it might be that people are leaving the country for short periods of time and then coming back. And then for other people, it might be stigma, making it very difficult to confront living with HIV. So there are a wide range of things, the reasons why people aren't coming. First of all, there is research that shows that if you do invest in people and make sure that you understand the reasons why people aren't accessing care. For instance, there have been some local studies in Liverpool showing that if you pay for transport, provide childcare, it did encourage people to come forward for care. But it's very, very expensive to do that, to have a model for individual people. The other research has shown that peer support really is effective, particularly at the point of diagnosis, in terms of allowing people newly diagnosed with HIV to talk to other people who have been living with HIV for some time, to help talk about what treatment's like, about what there's to be, talk about how to share your HIV status. And that's found to be really, really successful in making sure that people have the support that they need. So really, to improve retention and care, it's addressing those wider societal impacts, which means that people aren't prioritising HIV because of other things that are going on in your life, but also peer support and investing in peer support in the HIV services.
Thank you.
And can I add to that? First of all, it was some of the work of the Fast Track Cities initiative that has actually shown that particular link between peer support and retention in care. There's a study which I think Dr. Hamza might be going to refer to later from the Elton John Foundation in South East London, which showed, I think, one of the biggest barriers to engage retention in care was stigma, and that people that came back over and over again as a really important issue. But we are building on the previous work that we've done within Fast Track Cities, and we've now established a new piece of work, a collaborative piece between the NHS and the voluntary sector, which is addressing peer support in clinics, trying to ensure that every clinical service in London has peer support embedded within it. Alongside that, ensuring that things such as food security, welfare rights, all those wider determinants can also be addressed. But that is a partnership with voluntary sector organisations, and it's absolutely critical that those organisations are front and centre of those responses. So joined up care within wherever people need to get their care, and for some it may not even be in a hospital setting, it may be in a community setting, but making sure that the care is within the reach of the people that need them, and that it is enabling people to live well as just a medical service. So it's a wraparound piece that's absolutely critically important. And I think until we've got that right, we're going to struggle to ensure that people stay in care. And I would just add that people living with HIV are disproportionately living with other intersectional difficulties. They're likely to have higher levels of poverty, higher levels of insecure immigration status, lots of other things that would stop them getting care for all sorts of reasons and other conditions. And HIV stigma is just also compounding all those difficulties.
Thank you both. Jane, how has the approach of using an improvement community helped to reduce HIV in London, and how does this compare to other models used elsewhere in the UK?
So we've done two major improvement communities collaborations. The first one, at the first 2020 to 2023, we had 12 projects which encompassed 22 organisations. And the crucial piece here is that we used quality improvement methodology. They were projects where the work was not already being done elsewhere, and people were trying things out. They were iterative processes. So giving people the security of, or organisational security of 3 years funding to try things out, perhaps for them not to work, to go back, to realise it hasn't worked and to start again, and crucially to be working in partnership between voluntary sector and NHS organisations. And I think within that concept, we also had all those organisations meeting together as a collaborative. So each project was a a small collaborative, and then all the projects together were a large collaborative. And there was a huge amount of learning that went on through that. And coming out of that, there were one or two things that really shone out as being important. So peer support was critically important. And we've taken that now into the next layer, the next level, with our Getting to Zero collaborative, which is working on the same set of principles in terms of quality improvement methodology, but focusing very specifically on those pillars of ensuring people who are living with HIV are diagnosed in a timely fashion, that people who are diagnosed are able to access all the care they need, and that people living with HIV are living well, and that stigma is being addressed. So all those things are the core components of the current quality improvement methodology. So I think what we have here is something that is a collaboration. It takes out the elements of competition. People are not bidding, oh, we'll do this, you do that. It's all, if you do this and we do that and we do it together. And I think the partnership working has been incredibly important for the success that we've seen with our projects. What I hope will come out of it is a proof of concept and an evidence base that enables commissioners to see the value in taking that approach and enabling it to go forward. So we have got now, I think, in London, some really solid examples with very good evidence now about what works. The challenge is going to be to ensure that those are now picked up and are mainstreamed so that they can go forward.
Thank you. Thank you, Chair.
Thank you. Assemblymember Wilson.
Thank you. I think you've just answered one of the questions I was going to ask, which was about kind of following on from improvement community into then to fast track cities. So I think you've probably dealt with that. But so the I'll move on to the next question then. So I think there's some really interesting stats and discussions and some very positive news in certain areas. I think obviously particularly the success we've had with gay men, and it's, I guess, how we then can translate some of that success into some of these other groups. I was particularly encouraged, Jane, one of the comments you said earlier about you say we have the tools, we have the resources. So it's not just a question of we need more money to do. So we know what to do. But it's about how you can then get other groups to engage in that process and get the same level of success that that we've had with gay men and men who have sex with men. So I guess really what I'd like to ask is, given that we're not necessarily demanding more resource and more funding and so on, but what would you like to see? Now we have a new government, and it's an opportunity for a reset on all sorts of things. What in particular do you think the new government can do to show leadership in, say, broadening the success that we've had in the groups that we have had success with?
Gosh, there's so much in that question. But before I start, I do want to go back to the assumption that there's enough money in the system. There isn't. There's ways we can use the money we have, but the bottom line is that there is not enough resource, and I think without treading on the toes of panel 2, you're going to be hearing much more about that in the next panel, but we are seeing voluntary sector organisations going to the wall because of lack of funding, and we are seeing a workforce that is under-resourced and battered within the statutory sector as well. So before we start, it's not all hunky-dory, resource-wise. I think for the new government, the new administration, it's very good news that there is a commitment to refresh the HIV action plan. And in particular, the previous action plan had a number of markers and milestones, which, again, Alison's been working towards, and it's helped us know how we're doing as we go forward. It's very clear, I think, that one of the big issues we've been talking a lot today about ending new transmissions. However, Alison's also shown you the data on life expectancy, and even if we end new transmissions by 2030, there are going to be many hundreds of thousands of people living with HIV who are going to be living with long-term chronic condition with all the associated problems that HIV can throw up, particularly as you get older. So I think we have to look at how HIV fits into the long-term condition strategies. approaches, how we begin to reframe, because actually HIV is often missed out of some of those longer condition strategic approaches. Seeing HIV as one of many conditions that particularly older people are going to be facing, and making sure that HIV is seen as throughout the medical environment. I think there's also something that the new government can be doing about, and again, I don't want to tread on Jonathan's toes, but the public health support grant and the way central government funds local government and that relationship is really precarious, and we've seen the public health grant fall in real terms over the last administration, to the extent that it's even, you know, the local authorities who are deeply committed are finding it really hard to make their budget stretch. So I would really like the new administration to take a really serious look at what's happening between national and local government funding. If the resource for HIV prevention, community care is to remain in local government, there has to be a better funding mechanism, because that relationship is very precarious, even with the best will in the world. So those would be my two asks, my two immediate asks.
Assemblymember Best.
Thanks, Jane. Just coming on to the new government, or following up, I should say, on the new government, and obviously we had the report published recently by Lord Darzi. What did you make of that in relation to HIV?
Well, I think it's a very interesting report, because again, and I think the Secretary of State for Health has picked up on the need for looking at how health services are provided and what's happening in the NHS workforce. One thing I think that I have real anxieties about is that at the moment the money for HIV treatment and care sits within NHS England's specialist commissioning. That is going to be theoretically moved, or I think probably definitely moved into the ICBs. There's real concern about whether there is adequate capacity, oversight of what's going to happen when that happens. It risks a postcode lottery. It risks, for example, in London there are 5 ICBs. We know that several of them are really committed. We know that several of the others have not yet identified key leads for HIV. So the Darzi report on the structural changes within the health system are going to be incredibly important for HIV, and we need to be absolutely clear that there are HIV accountable officers within those ICBs, so that we can be absolutely sure that the budgets that are being transferred are actually adequate and being used in the right way. So we're lucky in Fast Track Cities. We have one of the chairs of the ICBs sitting on our leadership group representing the 5 ICBs. But I think that is something we really need to keep a very, very close watch on and be engaged with, and have an iterative discussion.
Thank you. Personally, I was disappointed with Lord Darzi's report only mentioning HIV once. I think that the new government has a long way to go to prove that it's going to take this as seriously as possible if we're going to meet the 2030 target, which I know everyone here wants us to. But in terms of the Mayor and his working with partners to reach the targets in 2030, is there anything more that you think the Mayor should be doing, or that you would suggest the Mayor could do?
So first of all, as I said at the beginning, we have had immense support from the Mayor and from his public health team, and I think that his championing of HIV as an issue that's a major issue of health inequalities has been invaluable, and I'd like him to go on doing that, advocating for HIV wherever he is able to do so. I do think, and I've mentioned this before, I think that there are now opportunities with the new Metro Mayor approaches for some of these things to be linked up, and I think that the role that the Mayor has in convening and in his ability to bring London together as a city is absolutely crucial, because we risk fragmentation, and we have got the Mayor as our overarching lead, and I think that's going to be really important. So his leadership is absolutely crucial. I would like him to continue and perhaps enhance his support for mental health support, because we know that mental health and HIV are two things that go hand in hand. And in fact, the ambassadors program that Fast Track Cities has been set up we used the suicide champions approach from the mayor as one of the inspirations for that. So I think if he could continue those initiatives, that's really important. I don't know if he is able to work with the ICBs, what the role of the mayor could be in bringing London ICBs together. And again, thinking about the mayors that are in those ICBs, whether there are relationships there. The Resilience Forum that was in place around COVID, I think has had some really interesting longer-term outputs that are very relevant to HIV, and it would be nice to see that continue. I think it has to be borne in mind that HIV goes beyond the health and care system. So wherever we can be in this city, whether the wider determinants of health, whether it be housing, food security, digital poverty was something that I know the mayor had a big interest in. And actually, as we go forward, thinking about the wider city, we are in the world's greatest global city. Arts, theatre, where else can we bring in the messaging around HIV? Where else can we see the HIV Confident Charter coming into play in areas beyond the health and care system, which the mayor has influence in? So quite a lot that he could be doing, in addition to the job he is already doing, of which we are very appreciative.
Thanks. And to pick up, I think, on that last point is one that this Assembly's talked about often. So in terms of the messaging, we've often made calls for a TfL campaign on testing. Is that something that you think would be a good idea?
I think it'd be a fabulous idea.
I should say a free TfL, because obviously you've just talked about the stakeholders and resources, so to make clear, a free TfL campaign.
Fantastic. Yes, please. And again, making absolutely sure that if you have a free TfL campaign on testing, which is absolutely brilliant, that people who test positive are going to be properly supported to be engaged in care and to remain in care, and importantly, that people who test HIV negative are able to be signposted to PrEP and to all those other prevention initiatives, which the London HIV Prevention Programme, which Mark Thompson is leading, are able to provide.
Thanks. And do you see any way that the mayor could use the GLA estate and convening powers to expand places for testing?
I think it's absolutely, just thinking about where people are is where people may be most likely to test. So I think it's really important that all those environments where people want to access care are properly are accessible and funded in the right sort of way. And the convening power of the mayor to do that, I think, is really important.
Thank you. Alison, Tamara, I don't know if you wanted to add anything to that or...
That was a very comprehensive list. The only thing I would add to is to ensure the mayor's inequality strategy does include HIV and sexually transmitted infection much more prominently than has been featuring so far.
Thank you, it's really helpful.
Thank you. Just making a note of that. No, thank you. Can I now ask? Can I now thank our guests for attending today's afternoon session and for their answers to our questions. We will now take a 10-minute adjournment before we welcome our second panel of guests. So we're expecting people back at 3:33. And welcome back to the Health Committee, and welcome to our second panel of guests, still on the same topic of HIV in London. We have with us Robbie Curry, who is the Chief Executive Officer of the National AIDS Trust. Welcome. Richard Angel, Richard Angel, OBE, who is the Chief Executive Officer of the Terence Higgins Trust. Welcome. And Dr. Lisa Hamza, who is a consultant at St George's University Hospital's NHS Foundation Trust and is also the co-chair of the London HIV Clinical Forum. So welcome to all of you today, and thank you for being part of our panel and investigation. So my first question actually is to all of you, so I'm going to start starting from my left to the right, so starting with you, Dr. Hamza. What are the main challenges that exist in London in reaching the target of ending new HIV cases by 2030?
So I'd really like to start by acknowledging how far we've come. I think that's the first thing to say. And we've made a real, and partly thanks to the efforts of Jane and Fast Track Cities, the Mayor, and the third sector organisations, we have made real inroads to meeting those targets. However, we also acknowledge that it's going to become harder, and we're going to have to work harder to get to the end game, which is what we're hoping to achieve here with the HIV epidemic in London. So I really want to frame the challenges around 3 areas, which I think have already been touched on by Alison. So testing, HIV prevention, and getting people into care and keeping people into care, but all underpinned by stigma, which runs through all of these areas as a major challenge. So we have to get testing right. We absolutely have to. And we've already heard that if you have a negative HIV test, this will give you This will give you access to HIV prevention services and health advice. If you have a positive test, it gives you instant access to HIV care and treatment. We have to test early as well. So something we haven't touched on yet is late diagnoses. So if you are diagnosed with a CD4 cell count of less than 350, so you already have immune suppression at the time of your diagnosis, in 2023 you were 10 times more likely to die in your first year after testing than somebody who was diagnosed with a more robust immune system. So that is really critical. We've already talked about the disparities with testing, particularly around heterosexual men, women, and also young people aged 15 to 24. Within sexual health services, all of these key groups have noticed reductions in testing. And as clinicians, we feel that one of these main reasons for reduction in testing is the challenge faced by our sexual health services. Secondly, HIV prevention, which I know my colleagues can talk much more about, but pre-exposure prophylaxis has to be considered, and we are seeing huge disparities in people who are able to access or even know about pre-exposure prophylaxis, and we have to tackle that. And then finally, obviously we need to not only diagnose people, but also keep people in care, and we've discussed a little bit, I know you've already talked some about people who know their diagnosis, but who struggle to engage in care, and how we get those people into care. And then finally, stigma, which we know runs as a barrier through all of these areas. So we know that it impacts the physical and mental health, mental well-being of people living with HIV. It causes poorer health outcomes for people living with HIV, and we know it's a barrier to both prevention and HIV testing. So I really feel that this is our main challenge as we move forward in the next few years.
Thank you. Richard?
I too want to acknowledge the huge success in London and how leadership in particular has played an important part in that. I believe the voluntary sector has done it, but particularly people living with HIV have been the best champions for themselves throughout this epidemic and have made sure our ambition in this area has stayed really high. I think for context, it's interesting that 13% of people living in the UK live in London, but 25% of new diagnoses are here in the capital. 37% of those with a detectable viral load and could potentially transmit HIV are living in London. 38% of those living with HIV are here in the capital, and 48% of PrEP users are within London. So while it is brilliant that the Mayor and yourselves have taken leadership on HIV, that is our role in London because it plays such a pivotal part in the epidemic. Meeting the 2030 goal is possible but not probable, and we aren't yet doing enough to get there. The previous panel talked about having all the tools available, and of course we have our wonderful NHS, which has the ability to deploy those tools. But there is a mismatch between those two things, and we aren't sufficiently applying those tools to our system and making sure we get the outcomes that we seek in our country and for this epidemic. So at the moment, I don't believe we will meet that 2030 goal, but I still believe we can, and I do believe that we have partners that are willing to get there with us. I want to focus on missed opportunities to test. This has got to be the most important one. We cannot stop the onward transmission of HIV if individuals don't know they're living with HIV and get access to that world-class treatment, the best doctors anywhere in the world, and the support from the voluntary sector that means they can live well with the virus. But too often we're seeing missed opportunities. In the previous session, there was a slide about those who were going to sexual health services but weren't offered a test. Why, oh why is it not automatic when you go to a sexual health clinic that you're automatically tested for HIV? I've heard all the excuses. None of them are any good. It should just be absolutely routine. And if in A&Es who've only been doing this for maximum 2.5, 3 years can get higher rates of testing in a busy A&E when they don't work in HIV than those who work in sexual health clinics, I do not understand why that can't be replicated. Our previous presenters and Alison showed brilliantly how women are so underserved by that system in our sexual health clinics. But it's much worse than those figures portrayed. They were only those who go and use essentially infectious disease gun services, if you will, in sexual health clinics. Those that are going for contraception aren't in those numbers. And that is disproportionately women. And of course, if you need a contraception appointment, it's not that you want a barrier method. You get condoms in the reception. You go in to have the barrier removed, a coil or a long-acting contraception setting, which of course increases your exposure to STIs and potential HIV transmission. Those women are not being diagnosed routinely for HIV while they're accessing those contraception services. Yes, you don't have to take a blood test while fitting a coil, but still, the purpose of fitting a coil increases transmission of HIV and STIs, and therefore a test is the only responsible thing to do. Because of the underfunding and the defunding, quite frankly, of our sexual health services over the last 14 years, partner notification is much less probable than it has ever been, and that is the highest probability of finding a positive test. But it requires a person to sit with somebody who has been newly diagnosed to do that work. Any fanciful ways of trying to make the internet do it for people just doesn't work. It's a thing that nobody really wants to do, is admit who they've had sex with or go back on the apps where they found them to tell them that news. But the only chance of it being effective is for somebody to sit with them, and you have to have health advisors to make that happen. Termination of pregnant services are also something that goes after you've had sex, where either you've not used a barrier method or the barrier method has failed. Why are we not routinely putting all STI screens as well as HIV tests in that service? I'm told that 80% of abortions are now done with 2 tablets in the post. Why don't we send one of the excellent SHL kits that we have here in London alongside that service? But still, we're seeing that if you go onto an infectious disease ward, maybe with TB, you are not automatically being tested for HIV while you're there. In Brighton, they did this as a pilot. It's like, would this be good practice? And you're like, how are we 42 years in this epidemic and you can go on an infectious disease ward with an indicated condition like TB and not automatically be tested for HIV? The same in dermatology, as well as indicated conditions elsewhere. I think that's a really important bit. And one of the things I would like this committee to recommend, if you'd be so kind, is that NICE, when they're drawing up the guidance, don't just put HIV testing in their HIV testing guidance. It needs to be in their termination of pregnancy guidance. If it says it should happen in one place, obviously if you're running a termination of pregnancy service, you look at their guidance about their service. You don't go and check all the others and say, I wonder where my service is referenced in the other 95 bits of guidance. If NICE could do that piece of completeness, I think we'll see the testing going up. The other thing I would say is access to online testing is one of the things that London has absolutely got right. In 30 of the 33 boroughs, you can get an amazing service through SHL, and it is definitely the leading service in the country. It's 25% cheaper than alternatives, it has more referrals than any other to normal and emergency contraception, see a higher testing for Hep C and detection through it, which is absolutely amazing and something we should absolutely champion. And I think that the other 3 boroughs who aren't in it should join and be part of it. I understand that funding is constrained, but I think it is a brilliant standard, and I think there are health inequalities in it not being provided. For those who most need that test, they're a Londoner. They don't know what borough they live in. They're a Londoner and they want to go through that service. But it doesn't have with it a click and collect service. So you can get sent it to your home, somebody else's home, maybe a partner or a friend, or to your workplace. But lots of people, particularly those who are affected by health inequalities, need to get it in a place where they can be completely anonymous. Through THT, as a charity, we provide at-home testing, and we have 4,000 click-and-collect sites across the country. It's used by 1 in 10 of the gay and bisexual men that use the service, but 1 in 4 of those who are black, gay and bisexual men, and 1 in 3 that are Asian. So you're more likely to be a house of multiple occupancy if you're from London's ethnic minorities, and therefore need to be able to get that test in different places. But crucially, you can't start PrEP during that online service. But the provider of SHL is Preventex, and they have developed the first online PrEP initiation service in West Sussex. So if we can get that here in London, you could see a massive transfer of the capacity needed in our sexual health clinics to online, freeing up provision there. So in Brighton, Terence Higgins Trust with the local clinicians are doing just that through an online app. It's released 1,000 appointments a quarter, and then the clinician time that would have seen those people now sees people in the community, and we have a sex worker clinic, we have a trans and non-binary clinic, and we have a migrants new to the UK clinic. People who wouldn't otherwise go and use a state service have found it in the community, being freed up because online testing has got lots of people who can use the service well out the system. London has the absolute infrastructure for doing that, and if we could make those big changes, we could make a big step forward in finding those who are tested. Thank you.
Thank you, Richard. Robbie?
First of all, I'd like to thank the committee for inviting me here today. I think that you've heard from my colleagues here and in the previous panel a range of things that we feel that would actually transform London's HIV response. But I do want to pay homage to the fact that we actually have an incredible surveillance system that enables us to actually be able to look at and to drill down into some of these initiatives and different settings and different needs that Richard has so eloquently kind of described. From that perspective, I personally sort of feel that one of the things that would be, well, very, very clearly we have, as has been described, we have all of the tools within the toolbox to actually eliminate HIV and to achieve our 2030 goals. So why aren't we doing it? Why aren't we necessarily achieving it? And very, very clearly, what Richard has articulated is little tweaks that we need to do because we've got a very, very clear perspective on things and some radical overhaul, like a PrEP re-engagement kind of service that we know that we need, a re-engagement into services and focusing on kind of PrEP that different parts of the system are not able to do that. So London has a huge opportunity really to be able to pull those strands together and very, very clearly articulate, and the Mayor has the opportunity, as we've already described, to convene people together to make sure that we get on track for London to eliminate HIV by 2030. So I won't rehash what's been said there, but as I say, I think we have a really good golden opportunity to be able to eliminate HIV by 2030, but only if we enact some of the initiatives that we've already described, or has already been described to us.
Thank you, Robbie. I'm going to turn to Richard for the next question about HIV-related stigma. And what progress do you feel has been made towards ending HIV-related stigma in London in particular? And what further action needs to be taken to reach the target of ending HIV-related stigma by 2030?
Stigma is a difficult thing, and it's a kind of amorphous thing, isn't it? It's the cloud that...
Microphone.
Stigma is a very difficult thing and something that's quite amorphous in the system, but I think we see it in as a sector in a number of different ways. There's about the anticipated stigma that somebody might have about going into their life, how somebody will respond if they tell them, whether that's realised or not. It's very real in their life. It's the stigma that you experience, and for people living with HIV, that is most likely to be in a healthcare setting, which is why the HIV Confidence Scheme run by National AIDS Trust, funded by Fast Track Cities, is such an important contribution to help our clinicians make sure that they create a non-stigmatising environment in our healthcare settings. Too often they fall short of that, and it is very often healthcare professionals that let us down in that system, particularly, I'm afraid, in GP surgeries and primary care. And from those, when you're out off the HIV ward, you often get double gloving and very appalling behaviours that shouldn't be there. And there's a lot more work that needs to be done there. And I think because of the high prevalence of HIV across the capital, it is incumbent on everybody in the NHS to be trained, at least to a small amount, on HIV, and particularly to understand the undetectable, untransmissible, what we call can't pass it on, message, so that they know that they're not at risk if they're working with anyone on HIV, but crucially they can do their practice that is informed by that basis. There's then the further work about the public and how they interact with HIV. So destigmatising testing is the single most important thing that we can do. If we remove that fear about knowing the result, that is really, really important. And whether it's Do It London or the National HIV Prevention England work that runs HIV Testing Week each year, we're making huge strides to make that happen year on year. But I think the bit where you see the pernicious stigma that consists in society is we regularly poll people about how likely you would be to kiss somebody with HIV, something that involves no transmission route at all, but you can see there the pervasive levels of stigma in the UK and in the capital about that issue, and we then need something really big to disrupt that going forward. The Scottish Government funded us to work in partnership with other voluntary sector charities to do the first TV campaign since the Tombstones. And that was able to shine a light on the experiences of people living with HIV when telling a family member, when using healthcare, when appearing on apps, and when they're in remote communities and somebody might find out about your status. And I think that did it in a way that meant that the person who might be stigmatising wasn't the subject of ridicule in the story, and took them on and revealed an experience. There's clearly others going forward. The one we're trialling at the moment, actually in Brighton, but we're hoping will be successful and we can take nationwide, is take the undetectable, untransmissible campaign, what we call Can't Pass It On, and we're trying to sex that up to make it very clear that it's about when you're having sex and you're not using a barrier method. If you're living with HIV and you take your medication, you cannot, no ifs, no buts, pass on HIV. And we've got to make sure that that falling into parlance and being best known isn't about toothbrushes, kissing, and the things where you've never been able to get HIV. The bit that's so remarkable about where we are is you can have sex, share fluids, have no barrier, and you cannot pass on HIV if you're taking your medication. And I think if we can knock down that stigma, you know, the original sin of HIV stigma is the idea people are quote-unquote infectious. If you're taking your medication, it isn't true. Anything we can use to share that message and get it to people, I think will make a big difference.
Thank you. Assemblymember Best.
Thank you. Richard, I'm just interested on that campaign in Brighton. Obviously, in the wider world, we want to make sure that people understand that protection in sex is important. Is that incorporated? Because obviously, wider, meeting anyone perhaps on a night out and taking a nice friend home with you, protection is important, right? It's not going to, that messaging isn't confused in that campaign you talk about.
Well, I think the first thing is none of us would be here without barrierless sex. We all exist for that reason, and those that didn't came back through IVF is in very small numbers. So I think, you know, that is the starting point for sex, and I think that's a really important thing to start from. And so if you're living with HIV and take your medication, you can have children that are HIV negative, you can have sex with your partner in the most natural way, and you cannot pass on HIV. So that's the first thing. Secondly, people living with HIV are doing that protection for us by taking their medication, and I actually think that's a thing that we should celebrate and lift up. We now, of course, have new technologies where you don't need to have a barrier method to stop the onward transmission of HIV if you're receiving it, by taking PrEP that is available for people, a new innovation conversations are coming there. But I think more generally we need to be talking about sex, and in that conversation we can talk about how you have control of your sexual health. And of course we would recommend condoms as a good way of doing that and stopping the onward transmission of STIs.
I understand the messaging that you're giving. I'm just saying the messaging in general of of all sexual health, especially. Robbie, I wanted to just ask you quickly about Richard already mentioned it, the HIV Confident Programme, and if you wanted to expand on that, especially in terms of the work you think that's done to reduce stigma.
Yeah, fantastic. Thank you. Richard described the various kind of forms of stigma, and we know that stigma towards HIV has been pretty pronounced, unfortunately, since the arrival of the epidemic 40-odd years ago. And unfortunately, a lot of that is also caught up in racism, homophobia, fear generally. And because stigma has been such a long and profound and pernicious, unchangeable kind of issue, we have done, throughout the decades, a series of investigations and research to have a look at actually what constitutes stigma and necessarily therefore how we can kind of address it. So we've been aware of HIV-related stigma for a very, very long time, and unfortunately we've not been able to redress that in any really meaningful, sustained kind of way. So through the Fast Track initiative, and equally through the 2030 ambitions to eliminate not only new transmissions, but deaths and whatever, but also to eliminate stigma, a programme was devised to actually look at how we might be able to do that. One of the ways of doing that is to raise awareness and through education, and the HIV Confident Charter Mark does that. We very clearly want to have a programme of where people and organisations sign up to reduce stigma through the Charter Mark. They go through a process to achieve that status, and it's an ongoing process. So there'll be initial sign-up and initial engagement with that, and then over time that we will hope that the organisations will continue to run that. We're already exploring. Certain organisations are looking at mandating that within their staff teams. So that particular kind of programme is already sort of evolving in a very, very different kind of way. What we do initially is that we totally recognise, the National AIDS Trust is an HIV policy, primary HIV policy and human rights kind of charity. So we are acutely aware of the need to ensure that policies are updated and anti-discriminatory and absolutely support people living with HIV. So part of what we do is we engage organisations in the HIV Confident Charter Mark. We ask them to run a survey within their staff teams, at different staff teams, and then based on the results of that survey from their staff teams, we have a series of bespoke e-training surveys that their staff teams can take, and then obviously we test them again, if you like, at the end of that particular process and see what necessarily has changed. We offer organisations an ability to be able to review their policies related to HR and to staff to ensure that their policies are current and up to date. We also encourage them to identify an HIV champion within their organisation that can support people that are living with HIV that may experience that kind of discrimination, so they can be supported through those particular kind of initiatives. The Positive Voices, the UK HSA report that people have previously mentioned in 2022, regrettably, as Richard has alluded to, points to the healthcare service as being an area that people experience untold levels of prejudice and discrimination and stigma. That is one of the bases of why, within the HIV Confident Charter Mark, that we are trying primarily to engage NHS kind of services, but also as a first wave. And we've already engaged quite a few trusts within London and several GP practices and things, and we've run some of those kind of surveys. And disappointingly, some of the actions that and behaviours that Richard alluded to, double glubbing, unsharing people's status and whatever, we see that within the results that we're kind of getting. We're also seeing that once we have delivered that kind of training, that people's understanding of HIV massively changes, and that therefore then that there is kind of great benefit. As was mentioned before, the London Fast Track Cities Initiative was the initial funder for that particular kind of programme, but we work collaboratively across the UK, and we are already now seeking to roll out HIV Confident across the UK, and are engaging a number of different kind of organisations throughout the UK and Scotland and Wales, and looking at Northern Ireland too, because we believe that this is a really fundamental initiative to start to turn the corner for that. As I said before, primarily within NHS services, but also increasingly across schools and companies and organisations. So we recognise that stigma may manifest itself very clearly for people living with HIV in the health service, but stigma, as I said before, unfortunately is associated with the early stages of the HIV epidemic and has not been redressed. So we totally recognise that this is a long-standing issue that we need to address, and the HIV Confident Charter Mark will do that. I know that you will ask me at one stage what the Mayor might be able to do to further that. Obviously, the City Hall was one of the founding members of the HIV Confident Charter Mark, of which we're enormously pleased about. But of course, anything that the Mayor could do to encourage other organisations, particularly business. Obviously, London has some of the, not only just UK head offices, but other offices as well. We would absolutely like the Mayor to be able to champion HIV Confident across the piece, and that is absolutely an action that we believe the Mayor would be able to do. Thank you.
Thanks, Robbie. Can I go back to, obviously, one of the measures I think you were talking about were surveys completed afterwards. I think a concern that I normally have with surveys is people understand my organisation wants me to say this, whereas the second part of it was talking about things like addressing double gloving. Is there evidence that you've managed to collect to show that it's changed practice? Changed practices, I should say.
Yeah, it's really interesting. I mean, we're still in this sort of initial sort of pilot stage of being able to look at that, and very clearly a number of those practices and behaviours we're saying are already very clearly within policy that shouldn't necessarily take place. So, for example, like double gloving. Interestingly, from the work that we have done with that is that, so let's just say, for example, in say like a GP practice, that's the entirety of the GP practice, and so we have noticed that very similar levels of misinformation and misunderstanding exist within both clinical and non-clinical staff. We've also done some of that within larger NHS kind of trusts, and we've also found that that is the case. That is the case as well, that it exists in all different echelons of that area. So we know that we therefore then need to do some additional kind of work with that. And very clearly the NHS organisations that have wanted to participate that are already signed up to be able to do that. And very, very clearly, I think the thing about it is the first survey will be, for example, is it okay to double glove working with someone with HIV? It's not quite the policy or the given answer and whatever. We've got some very candid answers from people of where they say that is completely possible, and then very clearly we deliver a training session to them. We say that that's not the best practice and that is actually unlawful practice. And yes, I appreciate that they may now know which one to tick, but at least they know which one to tick, and that we will then work with those organisations to address those behaviours.
Thank you. And I guess a question to the whole panel, really. Obviously, the AIDS Memorial is coming along with design now released. What opportunities do you think this has to address stigma? How can we use the opportunity of that launch and the media coverage that would obviously get to talk about stigma in HIV on a wider point today?
I suppose in a weird way it won't, because it will remind us of those that we've lost, and that is a really important thing that the city needs to do. And it is remarkable that a city of our nature and that experienced the AIDS epidemic the way it did doesn't have that focal point other than the Lighthouse Garden in West London. So I think that memorial is going to be really important for that, of just marking that point. And of course, it brings up the conversation of death and HIV, which is a thing that re-stigmatises the condition, if anything. I suppose what it will give us an opportunity to do is show the distance travelled. And I think the bit that's really exciting about working in HIV when you're educating people is there's nothing worse than a mythbuster, because it assumes your audience is stupid, right? But we get to say HIV has changed. So you don't have to myth bust. It is different now, so you can come in at this new stage with this new information, and that is what I think those of us who do memorialise, and we use World AIDS Day every year to say it's more than a ribbon, it's about remembering. It's more than a ribbon, it's about what we're doing today and how we resolve to make things better. And I think we'll use those things, and Ash and his team will try and bring those together, but it will also do a really important thing in its own right.
Thank you. I think that's a really important point around making sure that make clear the remembering, but also the moving forward. That's a really important part of the story.
Thank you. Assembly Member Ahmad.
Thank you, Chair. Good afternoon, panel. So my questions are directed to you, Lisa, but if anyone else wants to jump in, then please do. So, what has been the impact of opt-out HIV testing in London, and what further actions would you like to see on this?
It's been incredibly impactful, and I'll just go back a step and just sort of describe what's happened since April 2022. So obviously in April 2022, NHS England announced funding for opt-out testing. But interestingly, the remit was for areas of extremely high prevalence of HIV. So those are in areas in which there are more than 5 per 1,000 people diagnosed with HIV. London actually took a citywide approach, which was very innovative. So it rolled it out to the whole of London, regardless of the HIV prevalence. So there are a number of boroughs within London that fall below that prevalence level, so they sit between 2 to 5 per 1,000. And I think that's given us some really key information, which I'll go through. So the rollout itself was an incredible testimony, both to the team at NHS England and also to the NHS Trust that really did this at scale, with learning and sharing across organisations to bring all this together. And we now have opt-out testing in all, I think it's 28 ED departments across the whole of London. And to date, in London, we've done 2.2 million tests. And in London alone, we found 792 people with a new diagnosis of HIV. But it's not just about those with a new diagnosis of HIV. We have also tested a further 542 people who knew their diagnosis already but were not in care. So this is really important to give them the opportunity to allow them to come back into care. Of those newly diagnosed, more than 90% are now linked to care and accessing treatment, which I think is a fantastic testimony to our linkage to care and our ability to get people on treatment rapidly. And I think what's especially striking about the ED, well, there are a few things that I really want to pull out from this, but I think what's especially striking about the ED testing is who we're managing to capture within that testing. So we've already heard, and I think Alison alluded to it, they're publishing data, but we've looked at data in South London in our ED testing. And what we're seeing is all those people that we're missing in traditional testing services. So the people that we're picking up are, by and large, women, heterosexual, coming from black communities, and also predominantly from areas of deprivation. So they're living within the bottom few deciles of the index of multiple deprivation. So people who are at risk of health inequalities. The other interesting thing about ED testing is we're also finding people with quite advanced HIV who have not yet got unwell from an HIV-associated illness. So we're able to put them on treatment before they get sick, which I think is fantastic. So I think those are the real things I'd like to highlight. Firstly, that we seem to be testing people who are not accessing testing through other traditional services. We are testing those most at risk of health inequalities. And the interesting bit around testing in lower prevalence regions is that the new diagnosis rate within those areas, within that emergency department population, far outstrips that of the general population of that borough, really just demonstrating how powerful it is to test that cohort of people. And there's a few other bits that actually came out from data that was published prior in pilot studies prior to the ED opt-out testing rollout. And there were other advantages. Say, for example, partner notification, which we've already alluded to. We were able to pick up a number of people who were also undiagnosed through partner notification of people who we picked up through ED testing. and also to prevent transmissions to other partners or to children. And the other thing that I think is really key is we appear to be picking up people who do not consider themselves at risk of HIV because, for example, they've been in long-term relationships or whatever reason. And I think that is really powerful because if you don't think you're at risk of HIV, you would never consider yourself in need of a test. So I think that is really key. I wanted to also pull out something about why opt-out testing is so powerful, because this is the reason I believe that this is such a good initiative and why we should try and replicate this, as Richard said, in sexual health clinics. It avoids any kind of clinician input into the decision-making process, and that really is key. In all of these frontline services, everybody is incredibly busy, and if you have to think an extra step above and beyond what you're already doing to help somebody in an ED department, you're not going to see that uptake in ED testing. Whereas in most ED departments, we have more than 90% uptake. And that really is because we use implied consent. So if there are posters placed at strategic positions all throughout the ED departments, translated into many different languages, explaining about the programme. And unless obviously somebody doesn't have capacity or cannot understand that information, unless they explicitly say, I don't want to be tested, the test is automatically added on. And the other really key aspect, which I think is critical when we're thinking about potentially rolling this out to other services, is to remove the results management from that frontline service. You do not want to put any additional burden onto somebody who is rolling out ED testing, whether that be GP practices or whether that be emergency departments. So all the results management, all the reactive tests are directly sent to the hepatitis and the HIV service. And then finally, the other thing that I'd really like to say is that I really feel that by doing this, it's essentially a screening programme, but bundling it together with other bloodborne viruses such as hepatitis B or hepatitis B has really normalised testing across London. And actually, this is what people thought was happening all along. And I've lost track of the number of people that have come to me and said, but I had a test last year in A&E. Why didn't it tell me I had HIV? Because people think this is already happening. And not just for service users, but also for staff. I think this is really helping to tackle stigma and really raise awareness of HIV across the city.
Thank you. Richard, so did you want to add?
Yeah, I add to that just very briefly. So there's a couple of things I think to say about opt-out testing, and all that's been said is absolutely right. There is really one outlier hospital here in London that is not taking it up in the way that others have, and I think that should be mentioned, and it is Whipps Cross. Most of them are above 70% take-up, and they really are not even above 50% yet. And having recently been to A&E with a friend, there is nothing in that A&E that would notify that it was taking place, and I think that is really sad that that's been an outlier, and that should be dealt with as part of it. Secondly, that when we were arguing for opt-out testing, because it was we, NAT, THT and the Elton John AIDS Foundation that got the money that led to this programme started, we were using the fact that we do opt-out testing in sexual health clinics. And it wasn't until A&Es came along and said, OK, we're doing it and getting higher rates than sexual health services were, we were starting to say, but you're not really doing opt-out testing then, are you? So actually we took the example from sexual health clinics to another setting, and it turns out they do it better. And in fact, we now need to formally say we're doing opt-out testing in sexual health clinics to get that kind of behaviour. Also, when we were arguing for it, we used the Elton John AIDS Foundation pilot in South London, and that was really what drove this through and has been really phenomenal. The other part of that programme was to go through HIV clinic lists, those who hadn't seen a clinician for more than 15 months, call them up, try and arrange an appointment and get them back into clinic. That was hugely effective and found hundreds of people through that programme. They actually found more people by going through HIV clinic lists than they did by opt-out testing in the EDs. That bit hasn't been taken up as good practice yet, and it is time we had a HIV Retention England programme across the country, and of course here in the capital, where I would say the expertise of the voluntary sector, cheaper but as brilliant as many of our healthcare professionals, quicker to train than a nurse or a doctor, could do much of that work and find those people so they don't have to be found in A&E with potentially late stage HIV. The other thing, because we've done these different prevalence rates that's been talked about, is as you go down the HIV prevalence rate, we're not seeing the numbers needed per test for hepatitis or hep C going up significantly. So for HIV, in very high prevalence, you need about 1,500 tests to find a positive. In high, it's about 2,500. In low, it's about 5,000. But it's much more consistent for hepatitis C, about 900 tests, and the same with hepatitis be. So it shows the programme should be being delivered countrywide. So we've got an extension to 81 hospitals across the country. But the truth is, for hepatitis B and C, it should be being done everywhere. And of course, HIV should be done off the back. But I think we've done something really remarkable in HIV and shown the system how it should address health inequalities. Those who are poorest, minoritised and experiencing health inequalities are sitting in our A&Es and waiting. And if we're going to have waiting in those places, let's make a virtue of it. Who, while they're there, I was there for 8.5 hours with my friend. In that time, you could take an oral swab. You mostly have a pee. Some people will have a number 2. But you can take blood off everybody that is there. And if we could take that as a radical change in how we do our diagnostics in this country, we would actually put the tests where people most need them. And they trialled in just one hospital where we were doing opt-out testing outside London to add diabetes in. They only had 4,000 tests, but they found 40 people, which is 1 per 100. So imagine what we could do on the biggest issues facing the NHS. If we find diabetes early, there's a blood test coming for dementia, and there's now treatment that could stop the progression of dementia by 10 years. Just doing opt-out testing for dementia could save our health and social care system economics overall. So I think in HIV we've done something yet again that shows the whole of the health system how it should operate. And if you care about health inequalities, that's where you find the patient.
Thank you. The next question, Richard has given an answer to Lisa and Robbie as well, if you'd like to come in on this. So it is about making HIV testing more accessible. Richard was very clear about what he feels needs to be done. I wonder, Lisa, is there anything you'd like to add to that, and you as well, Robbie?
I think it's been alluded to before already that we have a number of kind of testing guidelines and frameworks and everything that already point to a number of areas where we need to elevate HIV kind of testing. We need those things fully implemented and the resource to actually be able to achieve those. But very, very clearly, I think opt-out testing has been the game changer that we have that has been brought to this, and equally its future kind of potential that Richard kind of alludes to. I think it's absolutely right that we look at different kind of settings now where opt-out testing could work, but we also need to be fully cognizant of the resource implications for that, and that needs to actually be fully resourced before that can be fully realised, I think.
Lisa, did you want to add to that?
I'd just like to talk a little bit about sexual health services, actually, because I think it's really key. We've talked a lot about how amazing opt-out testing is, and that's true. But we cannot lose sight of the fact that we are witnessing huge disparities in people who are not being tested through sexual health services. And why could that be? Well, our sexual health services are at breaking point. And I know that potentially in the next panels you will have people giving evidence about this, but I do want to highlight this at the moment. We are seeing year-on-year increases in numbers of people coming to sexual health services with year-on-year decreases in funding. I think 880 million since 2015 have been cut, and councils are struggling to provide these services. And here in the UK, we can't forget that sexual health and HIV services are actually entwined, and a threat to one is a threat to the other. And if we're thinking about getting to zero, we have to think about sexual health services as well. And the people that are and of course, I should mention that sexual health services have also undergone tendering processes and decommissioning in some areas, which has hugely, again, impacted on the ability of them to provide services, not just for testing, but also for pre-exposure prophylaxis. And the people that are attending these services are more complex. We are seeing increasing social and psychological needs of these people. And although we have a fantastic online testing service through Sexual Health London, that doesn't suit everybody, and there are people who struggle digitally to access these services, and often they are the people who are most vulnerable and most in need. So I think adequate funding for sexual health services will be key to help drive testing forward. But I think that HIV testing paradigm needs to shift, and I think we need to shift it more towards opt-out testing, but also to make it more of an acceptable test for people. So, for example, I fully support it being rolled out, understandably, with a cost implication to different frontline services, particularly GPs. But even simple things like, for example, the GP champions have been advocating for HIV testing to be part of the cancer of unknown origin pathway, which it should be through NICE guidelines, and yet there was pushback from a regional and national level to add the HIV test onto that pathway for GPs because it was felt too much work for GP services. So I think we've got a long way to go before people see HIV testing as something very routine and easy to deal with. And I think, yeah, sadly, I think there is a little bit of work to do that.
Thank you. My final question. Lisa, you alluded to and referred to the question that I asked about re-engaging people living with HIV and not in care. And we heard Professor Jane Anderson previously absolutely advocate for the voluntary sector to be, to be resourced, to be active partners in how we can take work forward. So I want to ask you the question that I asked the previous panel. How effective have programmes in London been to re-engage people living with HIV who are not in care? And what action would you like to see taken to expand those programmes?
So I'll talk mostly about the South East London programme because I think that has been the most systematic programme in terms of re-engagement in care that has happened in London recently. And it's an increasingly recognised challenge in terms of getting to zero. What we are seeing now is that people who are not in care are the ones who are presenting with advanced HIV and who are getting on well. And they've overtaken those in terms of a proportion of people who are seen on our hospital wards at the moment. And we know after about 10 years of care, we have a dropout rate of about 19%, and we've already seen how our 95-95 targets hide those people who know their diagnosis but are not in care. And I just want to highlight really that clinical recall work, which is done routinely by HIV clinics, so people who are at risk of dropping out of care or people who have recently dropped out of care, who are recalled and kept on recall to invite them back into care, is very different from re-engagement in care work, which is very detailed case finding from people who have been out of care for often many, many years, to try and find them and track them down and offer them care. And we know the benefits. I mean, there are very, very clear benefits, and we've talked about the benefits for the individual in terms of living a healthy life. But I also wanted to mention benefits for the wider population, not just in terms of transmission, but often these people are part of family units with dependents, young or old, and keeping them healthy and in care is vital because it has absolutely catastrophic implications for family units. And it's a significant cost implication, actually, for the NHS. So one London Trust, I think, spent £400,000 in 1 year on people who were lost, who were not in care and presented with HIV-related illnesses. And it's estimated that for each one single person who is re-engaged in care, the NHS saves around £220,000, which is a significant amount of money, considering it only cost about £56,000 per year for each of the trusts that were involved in this re-engagement in care work. So what this work was done, and it was originally funded through the Elton John Foundation, and now is taken up by the South East London ICS. So it's a funded project by the ICS. And they went through systematically in 3 of the trusts across Lambeth, Southwark and Lewisham, all of their patients who had not been in care, I think for up to 10 years, if I'm right in saying so. And they found, I think, approximately 800 patients, 500 of which they think that they could be contactable. So they cross-referenced them with UKHSA data to make sure that they hadn't left the country, weren't at a different clinic, already accessing care or had died. And they've managed so far to re-engage about 20% of this cohort. So just under 200 people, which is really phenomenal, really. The data is quite, we haven't got a huge amount of follow-up for these people. So I think so far we've got about 36% of those undetectable by 6 months. So that's a really good indication that they're doing very well in care. And it was really striking, even more so than the ED testing data, how this particular cohort of people were really suffering from health inequalities. So the majority of them from black communities, the majority lived in areas of high deprivation. They had high competing needs. They had, I think it was 23% reported substance use, 10% alcohol, mental health issues, stigma, unemployment were all incredibly high in this population. And as with the ED testing work, a large proportion of them had very low CD4 cell counts, so very advanced immune suppression at the time of re-engagement, which we have managed to avoid further morbidity and mortality by getting them back on treatment. And I think one of the issues is that stretched HIV services don't have the resource at the moment to do this. This is a very separate piece of work. There is crossover with the work that we do, but this is a much larger piece of work that should be resourced properly. And there exists quite a variation in care, quite a variation across London. And other ICSs, we've applied for money to try and get this similar resource to do such as is done in South East London, and that has been declined. So I think this is a real problem. And I just also want to highlight the importance of peer support with this, because actually without having peer support embedded in clinics to be able to offer that person peer support the moment they re-engage in care within what they feel is a confidential setting is critical, and we have to work with our third sector organisations to be able to provide that.
Thank you, Richard.
Can I come up on that? Exactly that point. So this is where the charity sector is subsidising the state in its work. So often to do that effective outreach isn't just the call you need, but you might need to put an intermediate service in place before they can get to their HIV. So we have Food Chain, our colleagues that do nutrition support for people living with HIV and making sure people can get food deliveries, or if they've got a newborn baby, formula milk for 12 months. So some of the things the third sector are doing is put in place that other support that you might need and help with those social determinants of health about why people aren't accessing care or what might keep them in care. But there's very little support and funding for any of that work to happen, and we have to continue to make appeals to the generous public and to trusts and foundations to supplement that work. But this really is the kind of mainstay of healthcare, of having people in and taking their medication. But that work wouldn't be successful, it wouldn't have got to 20% without that coterie of HIV organisations doing additional support.
Thank you very much. Thank you. And Robbie, did you want to add anything to that?
I suppose, whilst we're then talking about the third sector are absolutely crucial to be able to deliver these initiatives, really. And it is incredibly regrettable that as we see increasing budgets for NHS services, which very much are funded from local authority, we do not see the same level of support that actually is happening towards third and voluntary sector organisations. I mean, obviously, for some of you who may be aware, I was in a local authority up until probably 6 months or so ago, so I've got a bit of an understanding of some of the challenges that they are facing. But put it this way, where local authorities are required to support any financial kind of uplifts or staff uplifts and everything for the NHS, which is right, they are not required in any shape or form to be able to support third and voluntary sector organisations. So what you see and what we are experiencing is flat levels of funding, and we've been experiencing that for several years. And very, very clearly, that is not a flat level of funding, but that is actually funding cuts, consistent funding cuts for us to be able to deliver our services. And very clearly, the sexual and reproductive health sector is under incredible financial strain, as well as voluntary sector kind of organisations. And if we do want to achieve the 2030 goals, we absolutely need to make sure that the voluntary sector, as well as the statutory sector, are adequately funded to actually be able to achieve those things.
Thank you very much. Thank you, Chair.
Assembly Member Boff.
How easy is it to access PrEP in London, Mr. Angel?
Really difficult, and as somebody who's about to run out and
I've just tried to apply for some.
So if you go on Dean Street currently, you can't get an appointment for PrEP. There's no appointments available. There's no appointments if you have no symptoms, and there is no appointments if it says there's an option. Have you recently diagnosed positive for gonorrhea or chlamydia, and do you need a test? And if you click yes to that, you still can't find an appointment. So the point about the system being completely overwhelmed is so true, and you really have to be a quite persistent shopper around the system to do that. And of course, we know that entrenches health inequalities in the system. In the Mpox outbreak that happened, I was trying to acquire a vaccine and did it through my personal email first to be like, let's see if I can do this. But the local service in East London was not forthcoming and be able to get that service. And in the end, I emailed them from my THT account saying, for God's sake, it must be possible for me to get this. And still I got no reply. So it's really challenging. The services are absolutely overwhelmed, particularly in the capital. And getting access to a postal test can be much easier and is available all year round in those 30 boroughs and is a really excellent service, and you get up to 4 a year. But that PrEP initiation that goes with it isn't there and part of it, and that is very frustrating and clearly bad use of resources in the city. But otherwise, you need to, to get to start PrEP, you have to get into a sexual health clinic, and getting in the first place is really difficult. We did a mystery shopper exercise and found that 50% of the time people were turned away. It just is, and there's on average a 12-week wait to initiate PrEP. Across England. I don't know what it is in London, I'm afraid, but it's a real challenge getting PrEP, but we know it is such a game changer, and of course if you take it correctly you can't acquire HIV while taking it.
What needs to change?
Well, some capacity for our sexual health services would be remarkable, and I think
I mean specifically on PrEP.
Well, if you can't get through the door, and there's a waiting list to get through the door, I mean, literally, we need to make sure that our services can afford doctors and nurses to reply to those calls. I think that while we've got the current system, that is the single most important thing.
Why do you need to go to a sexual health clinic in order to get PrEP?
Because that's the current arrangement. That arrangement could and should change. But so while that's the current arrangement, that is what is needed. You need to literally get the door further ajar.
If there were, if we could remove that requirement, what then is in the way?
So being able to activate online is a really important one, and it looks like Preventex have overcome all of the challenges of being able to do that in West Sussex, and they run the SHL service with those 30 boroughs in London, and London is therefore a prime candidate for being the next place to do that. That will displace a huge number of those appointments in our
Could you explain that initiative a bit more?
So in West Sussex, you can go online, you do a normal STI and HIV screen the way that you might do through SHL in London, but in the blood vial, they also test your kidney levels at the start of taking PrEP, which is a thing you just need to monitor before you put somebody on PrEP and while they continue to take PrEP. And for most people who have a kidney problem, it'll either show up as you start or within the first 3 months of regularly taking PrEP. So you can now do that online. They send that away to the lab and the same assessment is done. And that means you can get sent essentially an e-prescription, and you can have your meds sent to you, or you can pick them up from the clinic environment. So that's what's happening in West Sussex. That's a really good service. Sadly, they've done it at the expense of clinics, because we live in this zero-sum game of sexual health, where if you do more online stuff, you have less doctors and nurses in the clinics. We need to find a way of breaking that model in this area to make that happen. I think the ideal is that you can have a digital prescription for PrEP, and you could go to a pharmacy who could dispense it around the country. I think getting pharmacies to prescribe is a challenge too great for us. I think Pharmacy First has not been a very good rollout as much as people wanted, with a series of things that pharmacy have been dispensing for a very long time. They've done emergency contraception for a long time, but Pharmacy First hasn't been great and the most successful initiative to make that happen. So I think we're not going to move to that point. But if you could dispense it, if you think of the people in London that might feel stigmatised and don't want to go to their local clinic, but go to the next suburb over, go to a pharmacy, get their PrEP, or those outside London that could, or in a more rural area, that can go to anywhere in the country to get their PrEP would be amazing.
Is what you're describing the same as the Emerge app
So the Emerge app is what we do in Brighton, but that's post you starting through a clinic. So that has offset those 1,000 appointments a quarter by people having repeat prescriptions. So people like me who are about to run out, they don't need an appointment. They can just go, and they can go to either our service or they can go to the clinic and they just pick up more PrEP. That's what PrEP Emerge has done. What they're trying in West Sussex is that you're starting and you do the whole thing online. You never actually have to meet a clinician, and that is perfectly sufficient healthcare for a lot of people. But some people will need that option as well. The other thing to say on PrEP is it is not currently available in any of our prisons, but we know people have sex in prisons, and it's really important that that changes, because the law says you should have access to the same healthcare provision whether you're incarcerated or not, and it is time that that changed. And I hope the Health Secretary has asked the medical director or clinical director of NHS England to sort this, among other things, and we're hoping that that will get done. But it is really important that PrEP is available in those settings.
I just tried to apply for PrEP online just to see what it was like, really. And apparently you can buy it without any kind of test. Is that correct?
Yeah.
So it's available for people with money?
Yes, and it has been. And people, because the previous government was so late to the table and National AIDS Trust had to take them to court, take energy to England's court to get it, lots of people did procure their PrEP online, and Dean Street provided an amazing service where people could check it beforehand, and THT came in to do verification of the provider and made that happen. Most of that has fallen away, so people are now just looking on the wild west of the internet to source their PrEP. Now it is mainstreamed in the NHS because people are struggling to get through.
Right. How effective are the HIV prevention services in the local authorities in London? I mean, I know from some experience that some are very good, but what's the general message?
I think the system is trying its absolute best and has done a remarkable amount of work with the provision that is available. And you look to Positive East, to Metro, to Spectra, and other organisations who operate in London who really are going above and beyond to try and find new diagnoses and to innovate in making that happen. We add to that with National HIV Testing Week and provide, it's the 1 week in the year where the central government will pay for the tests, and we try and do what we can to overcome those barriers. And last year we tested the highest number of black Africans that has ever been tested through that programme. So I think we're trying, but the truth is the resource is being cut in very real terms constantly for our colleagues. Our costs are going up and they are never realised. Robbie talked about that if you were an employer that plays Agenda for Change, the local authority is required to make up that difference. But if you don't pay Agenda for Change, there's no requirement to give you any uplift at all in any way, shape or form. And I've had to stop us providing a number of services because one contract was 11 years, of which we had no increase in our provision. That wasn't in London, that was outside, but the situation isn't massively different in London. Robbie will know about it better than I do, but people are trying their best with what we've got. But the truth is, it is really strained.
Mr. Curry,
Sure, thank you. I suppose I wanted to talk to the London HIV Prevention Programme. London has had a long history of HIV prevention. One of those prevention programmes was originally the London Gay Men's HIV Prevention Programme, which has a decades-long kind of history. All London local authorities contribute to that particular programme, and it is actually one of the only all London local authorities contribute to any kind of health programme across the board. And actually, that programme was when there was the transition from NHS to local authorities in 2012-2013, there was such concern across public health kind of departments at the time that programme might evaporate within the restructure, that they appealed certainly to the Mayor and to council chief executives to make sure that programme kind of continued. That programme has continued. That programme has a dedicated programme looking at GBMSM and a dedicated marketing and communication kind of programme as well. And very recently, it is now looking at a programme that will look at the needs of black Africans and black Afro-Caribbeans as well for London. That said, however, that programme equally, as Richard has described, is on flat funding. And as I have said, it's like going a new programme, a new arm to that programme looking at black Africans has been created from within existing resources, so has diminished the reach of the communications arm and the arm for GBMSM. So whilst it is fantastic that it is now actually looking more broadly, it is still not adequately resourced to be able to address the things that we need it to. Very, very clearly, we're in a very challenged place with HIV, but within our grasp and within our sights, we have the ability to be able to do it. Part of what we need to do is to do things differently. What got us to this place? I'm stealing I'm stealing the words of Kevin Fenton, really, so I'm not going to claim any credit for it. But, you know, what got us to this place will not get us to the next place. And very, very clearly, we are articulating some of the things that need to change to be able to do that. So some of the successes of the London HIV prevention programme, in particular, for example, some of the successes that have affected GBMSM, gay, bisexual and other men that have sex with men, isn't necessarily completely and utterly replicable to other kind of communities. Other communities have different demographics, different characteristics, different needs, different complexities that we need to address. So unfortunately, here it is that we have the ability, we have this within our grasp, and yet the system is actually trying to withhold or withdraw resources to us precisely at the time when we actually need more resources. Very, very clearly, Lisa has spoken about the cost saving to the system if we can identify people very, very quickly. We absolutely need to step up that ability to be able to save financial resources to the system earlier, but you know, we need lots of things to be able to do that. But very, very clearly, within the case of HIV, the case has been made consistently, and we need greater, not lesser, kind of investment in that. Not only will it actually save resources to the wider health and social care kind of sector, but very, very clearly it will improve health outcomes for individuals and communities, and therefore health outcomes for us all.
I'm curious that you said what you said at the time. My next question, supplementary, I was going to ask you about whether or not you've done the cost-benefit analysis, and presumably you've driven those into the ground, haven't you?
We have driven those into the ground, and there are lots of cases of where that is been clearly kind of articulated. I mean, there's lots of different studies that have been drawn out for that, and if the panel would like a summation of those, then I'm sure that's something that we can provide.
It might be helpful to see the work that you've done on cost-benefit analysis. Dr. Hamza.
I just wanted to add to that, really, and I think we've got two stories going on here. We've got people who know about PrEP and who are trying to access it, but we've also got a huge number of people who don't know about PrEP, and I'm thinking primarily here heterosexual men and women, and people who identify as trans or non-binary, and also men who have sex with men who don't identify as gay. All of these groups are hugely underutilising PrEP, partly because of knowledge, partly because of access, lots and lots of different reasons. And I think here we will really heavily rely on our third sector partners to really try and reach those specific groups, because there is something happening there. In terms of commissioning, I'm very pleased that you mentioned prisons, because that is a particular frustration of mine, that not being able to access PrEP freely in prisons. Commissioning is changing, and I hope that this will be for the better. So at the moment, you have to be a level 3 sexual health service in order to provide PrEP and get reimbursed for it. So if you provide PrEP out of that, that's out of your own pocket. It's not reimbursed by NHS. So, but that is changing, and I hope that this will really pave the way to allow PrEP to be provided in other settings, such as GPs, community pharmacies, prison services, and there will be new PrEP guidelines coming out probably earlier next year, which will support services in order to do this.
And one that's a question that's a little off tangent. My colleague asked a similar question on the previous panel. Do you think it would be a good idea if we were to promote sexual health services and HIV messages on the tube estate, on the TfL estate?
I'm happy to come into that. Yes, absolutely, unequivocally, yes. The difficulty of doing that is that I understand that Global really are a company that actually operate all of the advertising and things as well. So what influence the Mayor actually has to be able to do that, I'm not necessarily too sure.
He's chair of TfL, so he can negotiate that contract himself.
But we have worked with Global that own those spaces and have received kind of discounts. So if there are any discounts that the Mayor can unlock for that, that would be fantastic. Yes, of course.
Yeah, there's nodding there. I won't come back to the rest of you on that. Thank you very much indeed.
Thank you. Assembly Member Best.
Thanks, Chair. Richard, I wondered if you could talk to us a little bit about the HIV Ambassador Programme.
So the HIV Ambassador Programme has been funded by Fast Track Cities London, but it works off a programme that was developed by service users in Terence Higgins Trust called Positive Voices, where we go into communities, schools, care homes, and sometimes corporates to talk about HIV and dispel what people previously know about it, and to hear lived experiences. And you know, I'm somebody who loves to talk and prides myself on being able to get a message across, but these people are infinitely better. And when when Robbie or I share a panel with somebody living with HIV that's been part of this programme and talks about it, they don't remember anything we've said. They remember the life stories of somebody in front of them, how they were treated, how they were turned away often, and what they say to them about what can be done going forward. And through this epidemic, people living with HIV have been the most inspiring people who have really made sure there has been a call to action and that people after them have got a better service. And to see that in action still in London today is a really remarkable thing taking place, and I'm very proud of all of them. And it's been a really good way that the voluntary sector in London has come together to show, I'd say, the best of us, and it is in many ways, but we've shown some people who've had the toughest of experiences.
Thank you. How many people do you estimate you've reached? I mean, clearly not a precise figure.
I have a briefing on exactly this. Oh, this is good. So 27 HIV ambassadors have taken their personal story in more than 75 hours of education in just the first few months of the programme. 2,500 people have been in the audience, and we've been able to show the difference that they have made. We've done 20 talks alone in the Metropolitan Police and with PCSOs and wider safer neighbourhood teams. We can see that when we go in, we do, as Robbie was saying earlier, we do a survey of their knowledge on HIV pre the talk and the knowledge afterwards, and it is an absolute game changer for people to see that response. And you can see that people who know there's no risk of HIV transmission on your effective treatment go from 47% to 93% in those instances. Hearing from somebody living with HIV is a game changer.
That's a great briefing. Thanks. What opportunities do you see to expand on the HIV Ambassador Programme, or perhaps any other further opportunities in London?
I think that would be a great thing to expand, and clearly there's lots of opportunities there to make that happen. But I think if I had the opportunity to expand something in London, it really would be that work around those lost to care. What we're seeing in South London is a really best practice model about how you contact those people who've not been seen for more than 15 months and up to 10 years, and whether we get the record right that some have moved abroad or sadly have passed away for HIV or other reasons, but those who can be contacted must be, and some of them can only be re-engaged by a doctor, but no doctor's got the time to call through thousands of people. But what our colleagues can do is find those people that only the doctor can re-engage and get that down to the smallest possible list. And it seems to me that while we're looking for 5,000 undiagnosed people and that worst must continue, if we've got up to 14,000 people, and I think Alison Brown said 37% of those are here in London, there really is a piece of work to be done there. And I think if there is new resource available to do this, those people that we know are hurtling towards what we used to call an AIDS-defining illness, are those the people that we need to most be mobilising to support in the system. And that's where I would prioritise additional resource if we got the opportunity. And I think around that we talked about brilliantly, Lisa talked about how we have focused on those that might have caring responsibilities, and particularly those who are Black African. But one of the groups with that is men who are using chems in particular to deal with the stigma of HIV and coming to terms or not coming to terms with their diagnosis. And I think we've got to look at a programme that looks across those issues of those who have really affected by poverty and childcare issues, but those that are also using or misusing drugs, alcohol, and particularly some of these really pernicious drugs around chems.
Thanks. And finally, I spoke to Jane earlier about how we could widen testing, perhaps looking especially at the GLA estate or the mayor's convening powers. I mean, does anyone, Richard or others, have any further thoughts about where that could take place, how we could do that?
I don't know how much is about the mayor's estate, but the bit that we've learnt from opt-out testing is we've got to disrupt the health pathway that people are already using. Outreach is really important and there's a really valuable part of it. But in truth, the people who are having the worst outcomes are using our NHS, but they're being treated for the things that HIV shows rather than the HIV that's bringing on that indicator condition. And so we've got to focus, I think, and use this insight from opt-out testing to get the test in that place. So we talked about termination of pregnancy services, a really obvious place where clearly that a barrier has either not been used or has not been effective. Contraception services where you go to see a doctor to take away the barrier method. So I think there's a series of things like that where, like opt-out testing, if you're already using the service, if you're already getting your bloods taken, we need to add it in there. And I think there's a really important bit that you just alluded to on this. We've done lots of women, people of colour, etc. But men who have sex with men who don't define as gay, they're not just hard to reach. They don't want to be reached. They download an app, they have their sex, they delete the app. They're not waiting for a testing week advert. They might be going to a sex on premises venue. They might, they're evading our messages in lots of ways, and I think it's really important. And in lots of the things that we do, particularly in the LG space, we assume that everybody is out and everyone is out at work, and I think that really is not the modern experience for lots of people in London, and particularly those from Britain's ethnic minorities. And I think that's got to be part of the consideration when we're working in this space. The other thing, to speak to your question about resources, the nearer we get to zero, the more tests we're going to have to do. We're going to have to spend more money to find the next person. And what I'd like to see is institutions like the Mayor and the NHS owning that, because the return on investment isn't about how many tests you have to do for how many positives, for how many lifetimes. Imagine a world in which you can go about having sex and not have to worry about the onward transmission of HIV. That's the return on investment that we're working towards. We could be the first country in the world to do it. This could be the first city in the world, certainly the first capital city in the world to do it. And if we do it, it'll be the first time we stop the onward transmission of any virus without a vaccine, without a cure. And that is a prize that London can't miss out on.
I wonder if I might be able to come in. I think we sort of spoke about the convening powers of the Mayor, and obviously he has influence over, the police, fire service, faith groups and everything like that. So I think some of the initiatives that we've already sort of mentioned around sort of HIV ambassadors, HIV confident, and being able to gain access to some of those communities to be able to discuss some of these issues would also be of kind of great benefit. Thank you.
Thank you. Assemblymember Wilson.
Thank you, Chair. Before I ask my question, just a very quick sort of comment or observation. Richard, you mentioned Whipps Cross. That's my local hospital. Very disappointed to hear that their kind of uptake of testing is falling below others. So well done, and thank you for calling them out on that. And hopefully that will draw attention to that, and they can look to improve in the future. My question is to Lisa. So. With changes in the way that some services and NHS services are being commissioned and provided, and in particular with HIV to be delegated to the ICBs, what impact do you think that change might have? Are there concerns? I know in the earlier session, I think Jane mentioned that there was some of those ICBs haven't yet identified who's going to be leading on providing that. So is that a concern? Is it likely to be kind of lost in the maelstrom of all the other priorities the ICBs are going to be dealing with?
I think it's a huge concern, actually. There is still huge uncertainty about what delegation will look like come April 2025. And there has been a lot of work by colleagues, both in specialised commissioning, across the HIV clinical reference group, and hopefully also within the ICBs, to ensure that actually come the 1st of April 2025, we won't see much change. But what concerns me is perhaps not day one, but further down the line, day 365. Because theoretically there are huge advantages to holding all the money within the ICS. You can follow people from the time of their diagnosis all the way through their treatment, all the way through their lives until, for example, they may get sick and need secondary care. So I can see the advantages, but we do worry. There are a lot of, there are already existing inequalities. that will not be addressed before delegation. So what is there already will be baked into what we see in delegation already, and I think that is a concern. But I think our main concern as clinicians is really that ICS priorities don't align with HIV. So HIV isn't mentioned as a long-term condition, and that's despite work that the National AIDS Trust has done, really showing that many people living with HIV fit those priorities, the core 20+5 priorities that are championed by the ICS as really needing the extra funding. But HIV isn't mentioned among that, and I think that creates a real barrier to be able to ask the ICS to bring in services like the case finding for people not in follow-up. Or the other big issue that we are struggling as clinicians with at the moment is the HIV community clinical nurse specialists. So some ICSs fund those, South East London, for example, and they are absolutely invaluable. We talk about people with health inequalities and being able to put that health within their reach and they will take it. Well, that's how we reach many of those people. We actually go out to them if they can't come to us. But we can't do that without that resource. And I think all of these things are worrying us. And although it's not quite a larger problem as we have seen out of London, some of the clinics within London have seen huge increases in the number of people that are attending their services, and the funding has not changed across the years to reflect that, and we are concerned that that will end up in inequality and variation of care across London.
Thank you. So I have a question, I'll start with Richard. What are the main commitments that you'd like to see in the government's new HIV action plan?
Oh, this is my favourite subject at the moment. So I think there's a series of things. One, we want NHS England properly at the table. Like, for too long, they've said, oh, this is basically in prevention. We just do that little, the treatment stuff, and that's kind of hived off separately. And that is brilliant, right? And we know that from people with HIV. But the NHS England has got to take a more holistic route and come to the table. And there seems to be really good signs that is happening. And I think opt-out testing has become infectious in the NHS as a success story for health systems. And Amanda Pritchard, whenever she gets to go on the radio and talk about the success of the NHS, she mentions what we're doing in HIV. So we really need to make sure that they're in as a leadership partner. Testing currently is available free through an online service for 1 week in the year across the country. The rest of the time is 100 different contracts, 4 of which, of course, here in London, doing different things, where sometimes you get, sometimes only chlamydia and gonorrhea, sometimes HIV is added, sometimes only if you're in this community, whatever. We just stop. Like, we just need to have an all-year, always-on online testing service integrated with Hep C and other such initiatives to make that happen. Secondly, we need to see opt-out testing. There is a cliff of funding currently, particularly here in London. It will run out, the current money, on the 31st of March, and those 28 hospitals in London will need to cease doing that unless they make local decisions. We believe that central government should continue that programme, not just in London, but in all 81 A&Es across the country, and that if they're serious about their Hep C commitments, they need to be doing opt-out testing country-wide to make that happen. We want to see this re-engagement, HIV re-engagement programme across the country, because we won't be able to do anything about that loss to care group if we don't. And we need to have a serious initiative in our hospitals supporting HIV Confident and other such measures to make sure that healthcare settings are not stigmatised settings.
Okay. Does anyone else have anything to add on what they'd like in the action plan? Robbie?
You said most of them, but I've already talked about inclusion of HIV as a long-term condition, because I think that's really key. But I'd also like to just really highlight that tackling HIV-related stigma and inequalities is going to be key, and the funding for sexual health clinics. And I think Andrew, Boff, you already mentioned the need potentially for a national sexual health strategy, including HIV prevention, and I think that will be key, along with adequate fundings for our sexual health services.
Robbie?
I was just going to come in sort of talking about the paramount importance of reducing kind of stigma, but I've kind of made that point previously. Thank you.
Sure. And finally, so obviously we have spoken on this before as well, but is there anything finally that people would like to add in terms of what they'd like the Mayor to do that hasn't been mentioned already? Richard?
I think the Mayor has shown, and London overall has shown, remarkable commitment to HIV. We've seen it with all the candidates in elections, and we've seen the work happen between elections. I think that's been a really remarkable part of London, playing that part, not just at home, but across the UK and setting that example. But actually other cities, as Jane spoke earlier, look to us and take our example on many of those things. It'd be great to see the Mayor write to the new Health Secretary asking for that continued funding for opt-out testing, at least in the capital, but also to learn those lessons on hepatitis elsewhere and to make that happen. I think him to be a champion for testing. I know he's done some of that, but you've talked about other ways, including using the TfL estate that would aid that happening and make that take place. But him continuing, and I know he's done the Red Run in the past, and he launched HIV Confident last year, but that civic role that our Mayor plays on all of our behalf is really important, and the role of this Mayor and previous ones has been very crucial to that, and long may that continue.
Okay. Thank you. I think I'd like to thank all our guests for your contributions today. So can we note the report and today's discussion? Can we also delegate authority to me as chair in consultation with the party group lead members to agree any output from this discussion? And can we note the committee's work programme and the additional activity taken since the last meeting, namely the visit to Brentfield Primary School for the supervised toothbrushing scheme? And the date of the next meeting of the committee is on the 30th of January 2025. It's at 10 a.m. here in the chamber at City Hall. I have no urgent business, and I therefore declare this meeting to be closed.
Authority. Please stand by.